వినపడుతుందా నేను మాట్లాడుతున్నాను కదా? హలో, వినపడుతుందా నేను మాట్లాడుతుంటే ఇప్పుడు? వినపడుతుందా ఇప్పుడు? ఆల్ రైట్, థ్యాంక్ యూ. Great. Chalo, I hope I am audible and visible to all of you now. Okay, so a very good evening everyone. So let us start with a quick revision of the general medicine. So before starting the session, let me just tell you the topics that I'll be taking up for today will be the hepatology and as well as connective tissue disorders and as well as the endocrinology. So these are the three topics I will be taking, and if time permits, I will also do nephrology. So it all depends on the number of students who will be attending. So as of now, the number of students are around 104, right? And if it drops down drastically, then I'll confine myself only to 3 systems today. And if the number of students who are attending the session is good number, then I will finish the 4 chapters today. All right, so one chapter I'll take one hour, and the PDF of the today's session has already been sent on my Telegram channel, and my Telegram channel is Medicine Made Easy by Dr. Rajesh Gubba. So you can join on this particular Telegram channel. I have already sent these two topics right now, hepatology and connective tissue disorders. And once I finish hepatology and connective tissue disorders, I'll also be sharing the PDF of the endocrinology and as well as nephrology as well. Okay, so all set. Shall we start now? Okay. Now, starting with the first topic. So, in what way I have designed the entire revision session, I'll be telling you. So, I have completely designed all the topics in tabular columns. So, all the topics I have designed in tabular columns. You just go through the tables, that will be more than enough. And you just download that PDF which I have sent on my Telegram channel. Mostly, you don't require to write anything. You just listen, that's all. Because everything I have written in the tables itself, so you don't require to write anything. You just listen. Whatever I'm teaching, you just listen. That will be more than enough for you. All right. So let us start with the first session. Just give me a minute. Okay. Yeah, I will send you the annotation also. Yeah, so yes, I'll try my best to cover all the topics, right? And if you have not done medicine also, this particular revision session should be enough for you. I will not say 100% okay, but this should be enough for you, right? And if you attend this particular session, out of like the 40 questions that that comes in your general medicine, I can say almost like 75 to 80 percentage of the questions can come from these particular sessions. So I cannot say 100%, but 75 to 80% will definitely be covered from these particular sessions, right? Okay. So now let us start with the first topic, that is the alcoholic hepatitis. So in case of the alcoholic hepatitis, what is a very important thing that is very commonly being asked is the scoring system, right? So you have like PELD score, you have MELD score, like you have child pug score, and multiple scores are there, right? So this is one thing. Yeah, so this is one thing that will be asked very commonly. Yes, please answer this question first. Which of the following is not a parameter used in the PELD score? Age of the individual, serum creatinine, albumin, INR. Right. So please remember, in case of the PELD score, in case of the PELD score, the component that will not be there is your serum creatinine. Actually, the options are reversed, but please remember, it is the serum creatinine which is not the component of the PELD score. What exactly is your PELD score? It is pediatric end-stage liver disease. It is pediatric end-stage liver disease. So what are the parameters that you have in case of the PELD score? Like you have the bilirubin, right? Then followed by that you have the INR, then you have the albumin, then you have the age of the individual, then you have what is called the growth failure. Okay, so these are the components that you have in the PELD score, but creatinine is not the part of the PELD score. So, but whereas the creatinine, it is a part of the MELD score, that is model for end stage liver disease, right? Now I'll just show you one table which is containing all the scores, right? And this is very important stock question for your exam. What are the components of the MELD score? MELD score components are bilirubin, INR, and as well as the creatinine. What are the components of the MELD sodium? In case of MELD sodium, along with bilirubin, INR, and creatinine, you also have two more components, that is serum sodium and as well as the need for kidney dialysis, that is MELD sodium. PELD score just now I was discussing. And another important score, which is very much useful in case of the alcoholics or the alcoholic hepatitis, is like the child pug score. The parameters are bilirubin, INR, albumin, ascites, and as well as the asterixis. So I'm telling you, without revising this table, don't go to the exam at all. Without revising this table, don't go to the exam at all. This is one of the very important stock question. Either they will ask you the MELD score or they will ask you the child pug score and what are the parameters that are being asked. Okay, right. Now, what is the first important topic that I'll be doing as a quick revision is the alcoholic hepatitis. Okay, the first topic will be the alcoholic hepatitis. Right. Now, if you take this alcoholic hepatitis, okay, already I have said you this particular PDF is available on my Telegram channel, and my Telegram channel name is Medicine Made Easy by Dr. Rajesh Gubba. So you can join onto my Telegram channel and you can download this PDF, right? Now, you don't require to write anything I'm telling you, you just listen whatever I'm teaching, okay? Now, so if you see the spectrum in case of the alcoholic hepatitis, there are three important things in the spectrum. First, initially, the patient will develop the fatty liver. And if he continues to drink, then he will develop the alcoholic hepatitis. And further he continues to drink, then he goes into a state of the alcoholic cirrhosis. There's one stock question always been asked, what is the cause of sudden cardiac death if the individual is consuming a binge alcohol? Consuming of binge alcohol, the cause of sudden cardiac death will be the development of atrial fibrillation. And that is what is being termed by the Western people as the holiday heart syndrome. And next important thing you need to know in the alcoholic hepatitis is what will be the pathological features. So in the pathological features, I have given you the entire list of the pathological features, but what is the important MCQ in this pathological features is what you need to know. The MCQ in this pathological feature is the presence of the inclusion bodies and the name of the inclusion bodies, that is the Mallory-Denk bodies. Please remember, this will be a question which will be integrating your medicine and as well as pathology, right? But the examiner is like, if he is very much keen enough, he wanted to trouble you a lot, then in such case, what is that he may ask you is, yeah, is this video blurred or are you able to see the table properly? Yeah. All right. So next, so if the examiner wants to trouble you about the Mallory-Denk bodies, what is the next level of the question is, like he will be asking you, what are the other conditions where you have the presence of the Mallory-Denk bodies? So please remember, right? Please remember, it is observed in alcoholic hepatitis. That is what we are discussing. The other conditions will be in case of the obesity, right? That is the non-alcoholic steatohepatitis. Then the individuals with high copper intake, that is Indian childhood cirrhosis, and as well as Wilson's and primary biliary cirrhosis. So these are the other conditions where you have the presence of the Mallory-Denk bodies. And the next level of the question that they will be asking you in the alcoholic hepatitis is, what are the risk factors for the development of this alcoholic hepatitis? I'll tell you what is the question. The question is your HCV. Okay, so the HCV viral infection, this is a very important risk factor for the development of the alcoholic hepatitis. Now, what will be the clinical features? Very simple to make out, right? Hepatitis, right? So there will be inflammation of the liver parenchyma. So thereby, this individual will be having right upper quadrant discomfort, right upper quadrant discomfort. And as the alcoholic hepatitis progresses, the individual will go into a state of alcoholic cirrhosis. That is when the individual will have the palmar erythema, spider neve, Dupuytren's contracture, and the features of the portal hypertension will be there, right? Then, how will you diagnose this alcoholic hepatitis? See, one important, what is the first line investigation is the question that will be asked for you. What is the first line investigation in case of the alcoholic hepatitis? So that will be, that means first line imaging. I mean to say first line imaging. The first line imaging will be the ultrasound abdomen. What is that you will notice in the ultrasound abdomen? Within the ultrasound abdomen, you will notice that there is increased liver span. There is increased liver span. Then, what is a confirmatory test for your alcoholic hepatitis? That is another question. That is another question. And that can be the liver biopsy. What will be there in the liver biopsy? That is your Mallory-Denk bodies. So what are the other features that you will have in liver biopsy is there will be ballooning of the hepatocytes. There will be macrovesicular fat deposition, neutrophilic infiltration, spotty necrosis, and Mallory-Denk bodies. That is what you will observe on the liver biopsy, right? And next important is, because liver is the site where you have the synthesis of the coagulation factors, once liver is damaged, like what will happen? The coagulation factors are not synthesized. Thereby, what will happen to the PT and INR? There will be elevated PT and as well as the INR. Okay. Now, what is another important question that can be asked in alcoholic hepatitis? I'll tell you. That is about the enzymes. That is about the enzymes. So, what are these particular enzymes that are being elevated? So, the enzymes that are being elevated is your SGOT and as well as the SGPT. What is the question here, sir? SGOT, SGPT तो like हर hepatitis में elevate हो जाएगा. But what is the important question here that can be asked here is, you have to know that the SGOT to SGPT ratio, this will be more than 1 in case of the alcoholic hepatitis. Whereas you take in case of the viral hepatitis, SGPT to SGOT ratio will be more than 1 in case of the viral hepatitis. So this is a very important question that will be asked in your exam. Now, the next important thing is, just now I was discussing about the MELD score, right? And now, what are the parameters in the MELD score is very commonly asked question. What is that parameters? Just now, as I have said, the parameters that will be there is bilirubin, INR, and as well as serum creatinine. But what is the importance of the MELD score? The importance of the MELD score is that this will decide when to start the treatment. Now, if suppose if the score of the individual is more than 21, that is when you need to start the treatment with steroids. Okay, the treatment that you need to give is steroids, but the score should be more than 21. Okay. Now, apart from this, another important scoring system is the Glasgow score. Right? The another important score is the Glasgow score. Now, what is this particular Glasgow score and what are the parameters in this Glasgow score is? Yeah, please make a note of it. Age, WBC count, blood urea nitrogen, bilirubin, and as well as prothrombin time. And what should be the score to start the treatment? If the score of the individual, right? If the score of the individual, if it is more than 9, that is the point when you need to start the steroids. Okay, that is about the Glasgow score. And we have one more important score for the alcoholic hepatitis, that is Madry's discriminant function score. That is Madry's discriminant function score. Now, What is the role of Madrid's discriminant function score? Again, the same thing. This will also tell you about the severity of the alcoholic hepatitis. Now, according to your Madrid's discriminant function score, when is that you should start the treatment? If the score of the individual is more than 32, that is the point when you need to give steroids. So, MELD score के हिसाब से, according to MELD score should be more than 21 to start the steroids. According to Glasgow score, it should be more than 9 to start the steroids. According to Madrid's discriminant function score, it should be more than 32 to start the steroids. Okay, right. Now, what is the treatment? Right, what is the treatment that you need to start with? So first and foremost, the alcohol de-addiction. So how is that you will do this alcohol de-addiction? The alcohol de-addiction, it is done with the help of two important molecules, that is naltrexone or acamprosate. But what is the drug of choice? In any form of hepatitis, what is that you need to give is the prednisolone. Any form of hepatitis, in the sense alcoholic hepatitis, so you need to give the prednisolone. If the patient is having some contraindications because of development of the Cushing syndrome, then you need to start this pentoxifylline. Then you need to start the pentoxifylline, right? So this was about your alcoholic hepatitis. So what is the take-home message for the alcoholic hepatitis? That is, your SGOT to SGPT ratio will be more than 1. The first line imaging investigation will be ultrasound abdomen. Investigation of choice will be biopsy, where you will have the presence of the Mallory-Denk bodies. And the scoring systems which will decide to start the treatment is, that is your MELD score, Glasgow score, and Madrid's discriminant function score. And the drug of choice will be the steroids. So this is about your alcoholic hepatitis. Okay? Done. Once we are done with the alcoholic hepatitis, right. Now, the next topic for the discussion will be the cirrhosis and as well as its complications. Cirrhosis and its complications. Okay. Yeah, obviously, in case of the acute phase, we don't do the biopsy, right? But once the acute phase is over, that is when you need to do biopsy to confirm the alcoholic hepatitis. To confirm the alcoholic hepatitis. Okay, right. Yes. Yeah. Anyone want to make an attempt of this question? Match the following clinical scenario in portal hypertension with their respective choice of treatment. So one scenario is non-bleeding esophageal varices, in which scenario you will do. Bleeding esophageal varices, what is that you will do? Recurrent bleeding with class A child pug, what is that you will do? Recurrent bleeding with class B and class C child pug, what is that you will do? Yes. Okay. So now here, the answer is, I'll directly tell you the answer. The answer is B. Now in patients with the non-bleeding esophageal varices, in patients with the non-bleeding esophageal varices, what is that you will give is, you give beta blockers, either propranolol or the nadolol has to be given, right? Whereas in case of the bleeding esophageal varices, in bleeding esophageal varices, right, you will be giving the drugs like either terlipressin or IV octreotide should be given. Either terlipressin or IV octreotide should be given. And those individuals who are having recurrent bleed with class A child pug, in them, the peritoneal venous shunt has to be done. But in those individuals with recurrent bleed with class B and class C child pug, what is that you have to do in that individual is, you have to do TIPS. Right? You have to do TIPS. Okay. So this is about how the questions can be framed. Actually, this is a question of one of the complications of the cirrhosis of liver, that is portal hypertension. Okay. So now, what is the first thing that we will be discussing now is, I said you, like the entire medicine, I have just made it in the form of tables. I'll summarize each and every topic in the form of tables, right? And those students who are joining new, so the PDF of this particular channel, this session is already available on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. So you can download it from there, right? Next. So now let us discuss, or let me quickly recap the topic of the alcoholic hepatitis, right? So first and foremost question, this cirrhosis, I'm sorry, now let me discuss in detail about the cirrhosis. First and foremost question, cirrhosis, is it reversible or not? Yes, cirrhosis, is it reversible or not? So what you have to remember is, cirrhosis it is reversible, right? Cirrhosis, it is reversible in early stages, right? Cirrhosis is reversible in early stages. Now, in case of what is that early stages? Like you have the formation of the bridging fibrous septa, formation of the parenchymatous nodules, and there is disruption of the liver architecture. Now, when will this cirrhosis be reversible? Now, if at all, if you are able to stop that insult at the level of bridging fibrous septa, that is when the cirrhosis can be reversible. Then what are the various causes of the cirrhosis? Okay, like you have multiple causes: alcoholic liver disease, viral hepatitis like hepatitis B, C, D, autoimmune hepatitis, non-alcoholic steatohepatitis. Okay, I have given you this entire list. You can go through this. But out of all this, sir, question kya पूछ सकता है, right? If you take this nodules, you have micronodular cirrhosis and macronodular cirrhosis. Micronodular cirrhosis means where the size of the nodule is less than 3 mm. Macronodular cirrhosis means where the size of the nodule is more than 3 mm. Now, the question that will be asked is, what is the most common cause of the micronodular cirrhosis? The most common cause of the micronodular cirrhosis will be the alcohol, whereas the most common cause of the macronodular cirrhosis, that will be viral hepatitis. That will be viral hepatitis. Okay, that's a very important thing that you need to know in the entire etiology. What are the complications of cirrhosis of liver and what are the clinical manifestations? So, if you take the complications, like in patients with cirrhosis of liver, there is hypoalbuminemia and liver is completely congested. And because of which the portal hypertension, that will be causing ascites. The other complications are hepatic encephalopathy, hepatorenal syndrome, hepatopulmonary syndrome, spontaneous bacterial peritonitis. These are all the complications. And what are the clinical features like spider nevi, palmar erythema, Dupuytren's contracture, clubbing, parotid enlargement? Okay, a big list of the clinical manifestations are there. But what are the questions that I'll tell you? The question that can be asked is about this spider nevi. What is the cause for the development of spider nevi? Right? It is mainly because of increase in the estrogen level in case of cirrhosis of liver. That will be the reason for the development of the spider nevi. And increase in the estrogen level is also the reason for the development of the gynecomastia as well. Right? Next. And caput medusae. Why is this caput medusae? That's another important question that can be asked. So caput medusae, it occurs mainly because of the portal hypertension, and the portal vein, it has the anastomosis with the umbilical veins. Once the portal venous pressure is increased, the umbilical venous pressure is also increased, and that can result in the caput medusae. Okay, so these are the complications. Now, what are the scoring systems in case of the cirrhosis of liver? Almost the same, whatever we have discussed in the alcoholic hepatitis just now. That is your MELD score and as well as Child-Pugh score. Now, sir, what is important in this particular scores? You need to remember the parameters. See, even in your sleep also, you should not forget the parameters of MELD score, Child-Pugh score, and parameters of the Madri's discriminant function score, parameters of PELD score. You should never forget. That is one definitely asked question. So in MELD score, the parameters are bilirubin, INR, creatinine. Whereas in Child-Pugh score, the parameters are, right, in Child-Pugh score, the parameters are like the bilirubin, INR, the albumin, ascites, and as well as the asterixis. That is in case of the Child-Pugh score. And what is the purpose of doing this SAG? That is serum albumin minus the ascitic fluid albumin. Okay, that is what is SAG. So this will tell us whether the portal hypertension is present or not. If suppose, if the SAG value of the individual is more than 1.1, this tells you that there is portal hypertension. Now, what are the diagnostic tests? The diagnostic tests that you will be doing is the liver biopsy. So liver biopsy is the one which will confirm the diagnosis. But always, what is the problem when you are doing liver biopsy in patients with cirrhosis of liver? See, there is like abnormal coagulometry. The PTINR is deranged in these patients. There is excessive chance of bleeding tendencies in these patients with cirrhosis of liver, right? Now, you cannot do liver biopsy. So in such case, what is a non-invasive investigation? The non-invasive investigation will be transient elastography. Transient elastography. That will tell you about the liver architecture. Now, coming to the treatment that you will be giving in liver cirrhosis. So basically, what is the problem in liver cirrhosis? There is ascites, there is pedal edema, there is fluid overload. So for that reason, you need to give a salt restricted diet, and you should give diuretics. What are the diuretics that you will be giving? That is mainly you need to give the furosemide and as well as the spironolactone. And if the ascites is like massive ascites, then in such case, you need to do the abdominal paracentesis, or in case of the recurrent ascites, right? You are doing paracentesis, but again, there is accumulation of the fluid in the peritoneal cavity. If there is recurrent ascites, then you need to do a transjugular or transjugular intrahepatic portosystemic shunt. Okay. Now, coming to the management of the varices. So, in the management of the varices, you need to decide whether these particular varices are non-bleeding esophageal varices or bleeding esophageal varices. Agar non-bleeding esophageal varices are there, then you need to give beta blockers, and followed by that you need to do endoscopic variceal ligation. If it is bleeding esophageal varices, then what is that you need to do is you need to stabilize the patient first. IV fluids you should give, blood transfusion you should give, then you should give this terlipressin or octreotide, and followed by that you need to do this particular sclerotherapy. Followed by that you need to do sclerotherapy. So this will be the management of the varices. Now, the another complication that we were discussing was the hepatic encephalopathy. What is the drug of choice in case of the hepatic encephalopathy? That is lactulose. What this lactulose will do? This lactulose, it will convert ammonia to ammonium, and ammonium is excreted out. That is what is the mechanism of action of this lactulose. And okay, next important is there is development of spontaneous bacterial peritonitis. Now, what is the most common organism that will be causing spontaneous bacterial peritonitis? That will be the Escherichia coli. That will be Escherichia coli. What is the drug of choice that will be killing your Escherichia coli? That will be intravenous cefotaxime. That is considered as the drug of choice. Now, you should decide in a patient with cirrhosis of liver, when is that you should do an orthoptic liver transplantation. This is a very, very important multiple choice, guys, right? Very, very important question. If the MELD score of the individual is more than 17, that is when you need to do the orthoptic liver transplantation. That is when you need to do orthoptic liver transplantation. Done? Right. So that was about the cirrhosis of liver. Okay. Right. Now, yeah. Sir, how does cirrhosis cause Dupuytren's contracture? See, why there is Dupuytren's contracture in patients with cirrhosis of liver is, in patients with cirrhosis, there is excessive fibrous tissue accumulation within the palmar aponeurosis. And because of the fibrous tissue accumulation within the palmar aponeurosis, there will be development of the Dupuytren's contracture, right? Yeah, the beta blocker that we need to give is propranolol, right? Rather than carvedilol. In patients with the non-bleeding esophageal varices with portal hypertension, we give propranolol or nadolol. Where do we give carvedilol? Carvedilol, we give it in the congestive heart failure. Congestive heart failure, okay? Yes, for spontaneous bacterial peritonitis, we give the prophylactic antibiotic, and that prophylactic antibiotic is quinolones. We give either norfloxacin or we give ciprofloxacin as the prophylaxis. Okay, right. Now, chalo, next question. To the complications. A patient with chronic liver disease, ascites, and no bleeding varices presented with the hematemesis and as well as melena. What is the next step in the management? Give injection vitamin K, give injection tranexamic acid, fresh frozen plasma transfusion, platelet transfusion. Chalo, what is that you want to do, guys, for this patient? Very good. So, in this individual, you need to give fresh frozen plasma. Why is that you are giving fresh frozen plasma? See, the patient is having a chronic liver disease. So when the patient is having a chronic liver disease, does this liver can synthesize the coagulation factors? No. So whenever you give this vitamin K is required for synthesis of factor number 2, 7, 9, 10 by the liver. But here the liver itself is damaged. So your vitamin K, is it useful? No. So vitamin K is of no use. Tranexamic acid will stop only the bleeding, but it will not treat the underlying cause. So no role of tranexamic, no use of tranexamic acid here. Platelet transfusion should be given when the bleeding is mainly because of thrombocytopenia. But in patients with chronic liver disease, what could be the reason for bleeding? Because of defective coagulation factors. And this fresh frozen plasma contains the coagulation factors. That is the reason why you need to give FFP. Okay? Chalo. Then what is that we will discuss in detail now. So I'll be discussing in detail about the complications of the cirrhosis. Right? So the first important complication is what? That is portal hypertension. Sir, portal hypertension to humko pata hai, like what is the question that will be asked for us? I'll tell you two questions that are sure short questions, if at all, if they want to ask you the question on portal hypertension. One important is splenomegaly, right? What is the earliest finding that you will have in patients with portal hypertension? That will be splenomegaly. That will be the first thing. Second important question, what they can ask, if at all, if they want to ask you on the portal hypertension, is what is the criteria or what is the definition or what is the cutoff pressure to call it as portal hypertension? That is when the portal vein pressure gradient, if it is more than 12 millimeters of the mercury, right? So if the portal venous pressure, if it is more than 12 millimeters of mercury, portal vein pressure gradient, that is mainly what I mean to say is hepatovenous pressure gradient. If it is more than 12 millimeters of mercury, then it is considered as the portal hypertension, right? And the next important complication is definitely ascites. Already ascites के बारे में हम already discuss कर चुका है. Okay. Now hepatic encephalopathy. Now in hepatic encephalopathy, I'll be discussing that in detail as well. What is the question, if at all, if they want to ask you is, what is the toxin that is elevated or what is this toxic substance which is elevated for the development of the hepatic encephalopathy? That will be your ammonia. Actually, ammonia has to be detoxified by the liver, but liver is damaged here, so ammonia cannot be detoxified, right? And what will be the earliest manifestation in the hepatic encephalopathy? There will be reversal of the sleep rhythm. And these individuals will be in a state of confusion. There can be asterixis, and the individual can go into a state of coma as well. Then how is that you will manage this hepatic encephalopathy? Just now, as I have said, you need to give lactulose. And what is the purpose of giving this rifaximin and neomycin? Rifaximin is given mainly to kill the gut bacteria because I don't want the excess ammonia to be produced. So how can I achieve this? By giving rifaximin. Rifaximin will kill the gut bacteria, so excessive synthesis of ammonia will not be there, right? And next important abnormality will be coagulopathy, right? What is this coagulopathy due to? That is mainly because of defective coagulation factor synthesis by the cirrhosis liver. Then what is that you should give as a treatment? The treatment, what the preferable treatment is fresh frozen plasma rather than vitamin K. So how can you tell that the individual has developed coagulopathy? That is by doing the INR. So INR will be elevated in these patients, right? And one more important complication is spontaneous bacterial peritonitis. So already I have said you two questions. Most common organism, Escherichia coli. And drug of choice, cefotaxime. If at all, if they want to ask you another question on spontaneous bacterial peritonitis, what is that they will ask you? They will ask you about the diagnostic criteria for spontaneous bacterial peritonitis. Mainly, there should be, whenever you are doing the ascitic fluid analysis, in the ascitic fluid analysis, the polymorphonuclear leukocytes should be more than 250 polymorphonuclear leukocytes per cubic millimeter. That is what you will observe in case of spontaneous bacterial peritonitis. Okay? Next, coming to the variceal bleeding. Already I have discussed about the variceal bleeding also. So what will be the presentation in this individual? The presentation in this individual will be in the form of hematemesis, melena, and they may also go into a shock. And what will be, okay, there are three questions that I'll tell you. First line treatment in variceal bleeding coming with shock. First line treatment will be IV fluids, then followed by the blood transfusion, right? Next, what is the drug of choice in case of bleeding esophageal varices? The answer will be terlipressin, right? Then what is the treatment of choice in patients with a variceal bleeding? You should do esophageal variceal ligation. You should do esophageal variceal ligation. Now, one more question is, if there is recurrent, right? If there is recurrent variceal bleeding, then what is the treatment of choice? The treatment that you need to do is TIPS, that is transjugular intrahepatic portosystemic shunt. That is what is you need to do in case of recurrent esophageal variceal bleeding. Done? Ho gaya. Next important complication is what? The hepatorenal syndrome. Now, in hepatorenal syndrome, please remember, it is acute kidney injury that you develop in case of cirrhosis of liver. And what could be the reason for this? That is due to renal hypoperfusion. And actually, you have two types of the hepatorenal syndrome, type 1 and as well as type 2. But which is that which has worst prognosis? Type 1 wala hepatorenal syndrome has worst prognosis. Then, how do you treat these patients with the hepatorenal syndrome? You need to give the drug of choice in type 1 hepatorenal syndrome will be either terlipressin or octreotide. The other alternative will be midodrine, which is the alpha-1 agonist. Okay, so this is what is your hepatorenal syndrome. Next important complication is what? That is hepatopulmonary syndrome. Hepatopulmonary syndrome. Now, in patients with hepatopulmonary syndrome, what is that you need to remember is these patients will have orthodeoxia. These patients will have orthodeoxia. What is orthodeoxia? Orthodeoxia is that whenever the individual sits, they will have dyspnea, and whenever the individual lies down in supine position, the dyspnea will disappear. So orthodeoxia is a very important feature in hepatopulmonary syndrome, which is a complication cirrhosis of liver, right? And what is the differential diagnosis for the orthodeoxia? Differential diagnosis for the orthodeoxia. Yes, anyone want to answer what is the differential diagnosis for orthodeoxia? Yeah, see, overall, what is the most common cause for cirrhosis of liver? Overall, the most common cause for the cirrhosis of liver, it is the alcohol and viral hepatitis. These two are the overall most common causes, right? Yeah. So the differential diagnosis for orthodeoxia will be atrial myxoma, right? So this will be atrial myxoma, okay? Not ASD. It is atrial myxoma. All right. So this is about, and what is the treatment that you will be giving in case of hepatopulmonary syndrome? The treatment that you will be giving is the oxygen supplementation, and ultimately these patients will be requiring the liver transplantation. Ultimately, these patients will be requiring the liver transplantation. Okay, right. Now, apart from this, what are few more complications that can be seen in patients with the cirrhosis of liver? Few more complications that can be seen is the osteoporosis. Why there is osteoporosis in patients with cirrhosis of liver? That because liver is the site where you have the formation of the precursor of the vitamin D, that is 25 hydroxy cholecalciferol. 25 hydroxycholecalciferol, it is formed in the liver. When liver is damaged, your vitamin D is not formed, and that will result in the development of the osteoporosis. Okay. Next, malnutrition. Why malnutrition? Because liver is the site where you have metabolism of your carbohydrates, proteins, and lipids. And if liver is damaged, your gluconeogenesis does not occur, protein and lipid metabolism does not occur, and that will result in the development of the malnutrition. Now, what is this? The hepatic hydrothorax. So this hepatic hydrothorax is nothing but hepatic hydrothorax is nothing but the development of the pleural effusion. The patients who are having the ascites, the fluid can enter into the pleural cavity. That is what is called as the hepatic hydrothorax. And patients who are having hepatic hydrothorax, what is that they will develop? They will develop dyspnea, and that is due to pleural effusion. So how do you treat these patients? You need to give diuretics and salt restriction. Because there is pleural effusion, what is that you need to do is you need to do a pluricentesis, which is also called as thoracocentesis, which is also called thoracocentesis. Now, the another important complication is abdominal compartment syndrome. When will you develop this abdominal compartment syndrome is when the individual is in a state of tense ascites. When the individual is in a state of tense ascites, they will develop abdominal compartment syndrome. So in abdominal compartment syndrome, intra-abdominal pressure will be more than 25 millimeters of mercury. The intra-abdominal pressure will be more than 25 millimeters of mercury. And immediately you need to do the abdominal paracentesis. If you don't do abdominal paracentesis, the individual can go into a state of respiratory distress and respiratory failure. Right now, after doing abdominal paracentesis, if there is recurrent ascites, then what is that you need to plan for? You need to plan for the transjugular intrahepatic portosystemic shunt. Okay, so that was the story related to the complications in case of cirrhosis of liver. Okay, so I will show you one question regarding the complications. Yeah, please answer this. What is the maximum dose of the albumin that can be used to treat the patients with hepatorenal syndrome? So, what actually is the reason why you need to give albumin? Because albumin is the one which will cause the volume expansion and it can increase the renal perfusion. Right, very good. So, Anshad, can there be cirrhosis without hepatomegaly? So, Anshad, let me tell you, in case of the cirrhosis, initially it will be hepatomegaly. Later, there will be contracture of the liver. That is the answer for you, Anshad. And unlimited orthodeoxia is yes, orthodeoxia and as well as platypnea is one and the same. And any more questions? Indication for balloon tamponade in case of the variceal bleed. Yeah, see, when is it you can do the balloon tamponade is yes, you have an option called Sengstaken balloon that you can, with the help of Sengstaken balloon, you can compress the esophageal varices, right? So that is one of the alternative therapy where you can give as a treatment for the esophageal varices. Okay, when you are not able to do esophageal variceal ligation, the immediately what you can do is you can place the Sengstaken balloon, right? Yeah. So the amount of the albumin that we give is nearly around 100 grams. The amount of balloon that we give is 100 grams. Okay? Right. Chalo. Now we are done with the complications of the cirrhosis of liver and the cirrhosis. We will move on to the next topic, that is viral hepatitis. Next topic, that is viral hepatitis. And to those students who are joining as new, this PDF of this session has already been shared on my Telegram channel. That is Medicine Made Easy by Dr. Rajesh Gubba. So you can just download the PDF from that particular Telegram channel. Okay, right. Okay. So what is that? There should be a table here. The table disappeared. Okay, no problem. Right. What is that that will be asked very commonly on the viral hepatitis? Okay. So serology is very, very important. Chalo, anyways, what I will do, I will just do a detailed discussion of the viral hepatitis. First and foremost, nuclear material. What is the nuclear material in viral hepatitis? The nuclear material in viral hepatitis, it is the DNA virus, right? It is the DNA virus. Okay. Now, following that, you need to know, okay, the nuclear material is the DNA virus. Right. Following that, you need to know one important terminology that is called Dane particle. What is Dane particle? If you are able to visualize the complete virion that of hepatitis B under the microscopy, that is what is called Dane particle. Right? Now, what this is the question. This is a question here. What is the question here? What is the serological marker that appears first in case of viral hepatitis? That is HBsAg. So अगर वायरल हेपेटाइटिस के बारे में अगर क्वेश्चंस पूछना है तो the question will be on the serology. The question will be on serology. Okay. Now, coming to the core antigen. Please remember the HBC core antigen will never appear in the blood. Why? Because it will remain within the hepatocyte nuclei itself. Another important serological marker is envelope antigen. Envelope antigen, it will tell you about the replication and as well as the infectivity. Next important marker is the HBV DNA. HBV DNA, this will tell you about the quantitative assessment. Right? So this will tell you about the quantitative assessment of the hepatitis B. Done? Next. So this is like the serology related to structure. I did not still discuss the antibodies. Coming to the transmission. So if you see the transmission can occur by percutaneous, parenteral, and as well as the vertical transmission, right? Parenteral, percutaneous, then sexual transmission is another important transmission. There is one question asked, this was a PYQ, among the various viruses, which particular virus has the greater chances of spread via percutaneous injury or by needle prick? The options are the hepatitis B, the hepatitis C, then HIV. among these three viruses, which particular virus is being spread maximally by the needle prick? Anyone? Anyone? Very good. So it is the hepatitis B. So hepatitis B जो है, like the chance of transmission by needle prick is 30%. Hepatitis C, the chance of transmission is 3%. HIV, the chance of transmission is 0.3% by the needle prick. Okay, so please remember the percentages also. Done? Now, after having discussed about the antigens, then we will also discuss about the antibodies. So first serological marker is what? Surface antigen. Now to that particular surface antigen, you have the formation of the protective antibody, that is anti-HBs AG, right? And I said you that core antigen will never appear in the blood because that will remain within the hepatocytes. Okay, then what is the antibody to the core antigen? The antibody to the core antigen is the anti-HBC AG, right? And this particular anti-HBC AG, what will be the antibodies? That is the IgM and IgG. IgM anti-HBC in case of acute viral hepatitis. IgG anti-HBC present in the chronic viral hepatitis. Envelope antigen already I have discussed. That is the one which is seen in case of the high infectivity. Now, next to the serology, if at all, if they want to ask you one more question related to the enzymes, already I have said this in the alcoholic hepatitis also, but let me repeat once again. So, SGPT to that of the SGOT will be more than one in case of viral hepatitis. Whereas in case of alcoholic hepatitis, what is that you will have? You will have exactly reverse. That is SGOT to SGPT will be more than one in alcoholic hepatitis. Done? Next. Coming to the diagnosis, I have already said you that is by your viral load and serology and all. Okay. What is the question here is, the question is on the ultrasound abdomen. Ultrasound abdomen in acute viral hepatitis, what is the appearance? That is the starry sky appearance. And this starry sky appearance, I hope like you know all these questions, right? Lymph node biopsy showing starry sky appearance. Where is that you will have lymph node biopsy, starry sky appearance. Very good. Burkitt's lymphoma, right? Then CT brain starry sky appearance. Where is that you will have? Very good. That is neurocysticercosis. Done. Then renal biopsy showing the starry sky appearance. Where is that you will have? Very good. That is in case of the post-streptococcal glomerulonephritis, right? So these are the four questions on the starry sky appearance. Okay. Now coming to the treatment of the acute hepatitis B. Please remember, in acute hepatitis B, you don't give antiviral drugs because 90% of them, they'll have spontaneous recovery and only supportive care has to be given. Symptomatic management has to be done in case of the acute viral hepatitis. Okay. Then followed by that, the chronic hepatitis B. Chronic hepatitis B, you need to definitely give antiviral drugs. Question क्या पूछ सकता है in the treatment of chronic hepatitis? Please and please remember this criteria in order to start the antiviral drugs. So, envelope antigen should be reactive. HBV DNA viral load should be more than 2 into 10 to the power of 4 international units per ml. And the SGPT should be elevated. That is when you start the antiviral drugs. And which antiviral drug you will start? That is tenofovir. And for how many days you will give? 300 milligrams per day, 48 weeks you will give. And whenever you're giving tenofovir, what is it you need to monitor? You need to monitor the kidney function. Okay, so this is about the treatment of the hepatitis. And what is the complication? Chalo, your viral hepatitis is the one which will be causing cirrhosis and as well as the hepatocellular carcinoma. Okay, now do you have vaccines available for the hepatitis B? Yes, vaccine is available for hepatitis B. Vaccine is available for the hepatitis A and as well as the hepatitis E as well. But the question to be asked is, for which virus the vaccine is not available? For hepatitis C, vaccine is not available, right? This is about the hepatitis B. This is about the hepatitis B. Okay, now we'll move on to the next discussion. Right, so far so good, everything is fine. How is the session going on? Right, just I think 40 minutes over. As of now, I think everything is comfortable, no problem. Chalo, ठीक है. Now we'll move on to the next Hep C, Hep B, and the fulminant hepatitis. Chalo, you see this question and please answer. I'll be just back in 1 minute, guys. Only 1 minute. Yes. So am I audible and visible to all of you? All right. Chalo. So what is that you have decided regarding this answer? What is that you people have decided this answer? Uh, please motivate. See, medicine is so voluminous that I don't get adequate time for completion of the topics. And for me to motivate and spending the time on motivation, I will try my best in between. Right. Okay. I let me just continue the flow. In between the motivation comes, right? So just give me some time. Okay, so match the following hepatic virus with their respective diseases. Chalo. So what is the correct answer here? The correct answer here is C, because the hepatitis B, it is a transfusion related hepatitis, right? And the hepatitis E, if you see, it is the fulminant hepatic failure in pregnancy. Then you take the hepatitis C. This is the one which commonly requires the orthoptic liver transplantation. And hepatitis D, it always requires the co-infection with the hepatitis B. Chalo? Chal. Now we'll start with the discussion of this individual viruses. Now, regarding this, the hepatitis C, what is the question that can be asked regarding the nuclear material? So, regarding the nuclear material. For hepatitis B, I said you it is DNA virus, but for hepatitis C, please remember it is a single stranded, the RNA virus, right? And if at all, if the question has to be asked on the hepatitis C, what is very important, as already I've said you about the vaccine. Vaccine is not available. And what are the antibodies in case of the hepatitis C? The antibodies in hepatitis C is the anti-LKM antibodies. The antibodies are the anti-LKM antibodies. And among all the viral hepatitis, please remember the viral hepatitis which is associated with the extrahepatic manifestation, that will be your hepatitis C. What will be that extrahepatic manifestation? I have given you the list there, right? One thing please remember, they have given you 4 options of hepatitis A, B, C, D, but some Extrahepatic manifestations are there in the given clinical scenario. Blindly close your eyes and mark your hepatitis C, right? So what will be that extrahepatic manifestation? Arthralgia, myalgia, paresthesias, lichen planus, aplastic anemia, diabetes mellitus. So these are all the extrahepatic manifestations. Okay. Then what is the antiviral drug? Actually, what is that we were giving in case of hepatitis B, we were giving tenofovir. But here we give actually according to the genotype. But the commonly used the antiviral drugs are sofosbuvir and velpatasvir. That should be given for 12 weeks. And the other important antiviral drug for the hepatitis C will be glicapravir plus pibrentasvir. That will be the antiviral drugs for the hepatitis C, right? And is there any post-exposure prophylaxis for hepatitis C? No. For hepatitis B, you have the post-exposure prophylaxis. Then how is that you will confirm the hepatitis C needle prick injury? So hepatitis C needle prick injury, it is confirmed by the HCV RNA PCR for confirmation. That is for the hepatitis C treatment. Now, we were discussing about the hepatitis D. So hepatitis D, I said you it is always an incomplete virus and it requires always a company of the hepatitis B, right? So this requires the hepatitis B co-infection. And how is it being transmitted? That is parental route. So what is it required for? The life of it, that is HBV. So HBV should always be present. Now whenever there is HBV co-infection, there is increased chance of the fulminant liver failure. There is increased chance of fulminant liver failure. Now if at all if you want to eliminate the hepatitis D, what is that you need to do is you vaccinate. You give 100% hepatitis B vaccination that will eliminate the hepatitis D, right? So that was the story of the hepatitis D, which is called Delta virus. One more important is fulminant hepatic failure. What is the criteria to call it as fulminant hepatic failure? The criteria to call fulminant hepatic failure is if there is rapid liver destruction within 8 weeks, that is called the fulminant hepatic failure. What are the causes for fulminant hepatic failure? Okay, you have many things. You have toxins, you have the viral infections. So, and among the viral infections, the very important viral infection is the hepatitis B and hepatitis D co-infection and hepatitis E in pregnancy. Hepatitis E in pregnancy, right? And the next important is the workup for the fulminant hepatic failure. So the workup, okay, the usual workup for any liver pathology, SGOT, SGPT, coagulogram, USG abdomen, and then the MELD score. What is the treatment? See, the problem in patients with the fulminant hepatic failure is they go into a state of the hepatic encephalopathy. So what is the drug of choice for hepatic encephalopathy? You need to give lactulose. And I already said you why you should give this rifaximin and as well as neomycin. So you should give rifaximin and as well as neomycin mainly to prevent the bacterial growth. Then you should also give the drugs which will convert the ammonia to glutamine and the glutamine is excreted by the kidneys. So what is that particular drug that you will give? That is LOLA. What is LOLA? That is L-ornithine L-aspartate, right? L-ornithine L-aspartate. That converts the ammonia to glutamine and that glutamine is excreted by the kidneys, okay? And in refractory cases of the hepatic encephalopathy, what is that you will do? You have a form of dialysis that is called MARS. What do you mean by this word MARS? That is molecular absorbent reabsorbent circulating system. That is what is called MARS. And already I have said you when to do the orthoptic liver transplantation. Orthoptic liver transplantation has to be done mainly when the MELD score is more than 17. That is when you need to do the orthoptic liver transplantation. Okay. So this is about the story related to the fulminant hepatic failure, right? Next topic is the autoimmune hepatitis. Next topic is autoimmune hepatitis. And in autoimmune hepatitis, what are the antibodies? The anti-LKM antibodies. Okay, chalo, match the following. Anti-LKM 1, 2 and 3. Match the following, please. Yeah, one is your super infection and co-infection. That is one important question that will be asked in hepatitis D. Right. So yes, very good, Anash. The answer is C, right? The answer is C. So anti-LKM1 that is associated with the hepatitis C. Anti-LKM2 that is observed in drug-induced hepatitis. Anti-LKM3 that is present in the HDV infection. that is present in HDV infection. Okay, so this autoimmune hepatitis, if you see, there are three types. What are the three types of these autoimmune hepatitis? These are the three types of autoimmune hepatitis. That is autoimmune hepatitis 1, 2, and as well as 3. So this autoimmune hepatitis 1, the antibodies are anti-nuclear antibody, then anti-smooth muscle antibody, and soluble liver antigen. Whereas autoimmune hepatitis type 2, the antibodies that you will have is mainly anti-LKM1, 2, and 3. 1 in hepatitis C, 2 in drug-induced hepatitis, 3 in hepatitis D. And autoimmune hepatitis type 3, the antibody is anti-soluble liver antigen. That is your autoimmune hepatitis 3. Right now, what are the questions that can be asked for you on the autoimmune hepatitis? What is another name for autoimmune hepatitis? It is called as leukoid hepatitis or plasma cell hepatitis. Leukoid or plasma cell hepatitis. What could be the reason? Because there is association of the SLE. That is the reason why it is called as the leukoid hepatitis. And in the pathophysiology, which particular cells play an important role in the attack of the liver antigens? That is the T8 mediated attack. T8 mediated attack. What are the etiologies? Already just now I have said you about the types of autoimmune hepatitis 1, 2, 3, and depending upon that you have the various etiologies. And always remember, these autoimmune hepatitis, it is associated with other autoimmune conditions. What are the other autoimmune conditions? Like hypothyroidism, Hashimoto's thyroiditis, malabsorption syndromes like the celiac flu and ulcerative colitis, and renal pathology, that is membranoproliferative glomerulonephritis. Right? And regarding this anti-LKM 1, 2, 3, already I have discussed. But please remember, in case of autoimmune hepatitis, we have a form of ANCA called ex-ANCA. Actually, ANCA, like how many types you have? P-ANCA, C-ANCA. P-ANCA is present in microscopic polyangiitis and Church-Strauss syndrome, and C-ANCA is present in case of Wegener's granulomatosis. But in autoimmune hepatitis, what is that you'll have is the ex-ANCA is being present. Ex-ANCA is being present in case of the autoimmune hepatitis, right? Now, so next coming to the clinical features. Clinical features, what it will be there? It will be like same to that of any liver pathology, right? Initially they will be asymptomatic, later they will be developing jaundice. But here the additional features that they can have is associated autoimmune conditions. Like for example, autoimmune hepatitis, if it is associated with Sjogren's, they can have Sicca syndrome, right? And if this particular autoimmune hepatitis, if it is associated with sarcoidosis, they can have this erythema nodosum. And all other features of the liver problem like cirrhosis, ascites, variceal, everything is same, right? And is there any risk of cirrhosis in these individuals? Definitely. Which particular patients of autoimmune hepatitis will go into cirrhosis? That is observed in elderly patients. That is observed in the elderly patients, right? Now, in the workup of autoimmune hepatitis, you need to work up for the liver function, and you need to work up for the underlying etiology like viral hepatitis, HIV, HBV, and HCV. Obviously, your PTINR will be raised because liver is damaged. RF factor can be positive because it is associated with many other autoimmune conditions. And always this autoimmune hepatitis, it is the diagnosis of exclusion. That means first you need to exclude viral etiology. You need to exclude the drugs, alcohol, genetic causes. After excluding all others, then you need to consider it as autoimmune hepatitis. Now, in any autoimmune hepatitis, basically what is this? It's an autoimmune condition, right? So what is that you'll give? Steroids dena hai. So you should give the steroids. And what is that particular steroid? That is prednisolone. Okay. Now, but this you cannot give for long term because the individual may develop Cushing syndrome. So what is that you need to give in order to prevent the development of the Cushing's as a maintenance? As a maintenance, you need to give the azathioprine. In the late stages, what is that you will do? In the late stages, you need to do orthoptic liver transplantation. In late stages, you need to do orthoptic liver transplantation. Okay. Now, is there any recurrence after doing orthoptic liver transplantation? Yes. Autoimmune hepatitis may recur in the transplanted liver. Okay. So this is about the autoimmune hepatitis. This is about autoimmune hepatitis. So what is very, very important in autoimmune hepatitis that you need to remember? This table is very important, right? Which antibodies are present in autoimmune hepatitis type 1, type 2, and as well as type 3. And where is that? You will have anti-LKM1, anti-LKM2, anti-LKM3, right? Now, we'll move on to the next topic in the liver, that is the Budd-Chiari syndrome. And those students who are joining now and completely new onto this particular channel, let me tell you, the PDF of this particular topic is available on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba, right? And if you are liking my session, right, you can follow me. You can follow me on my Instagram handle, that is Rajesh Gubba, right? Why is that you need to follow me? Because I'll be posting the clinical material on my Instagram handle every day, so you can just follow and you can just go through the clinical material that I'll be posting every day on my Instagram handle. Okay. Now, coming to the clinical scenario, like a female presents with the severe abdominal pain. Examination shows jaundice, tender hepatomegaly, and mild ascites. What is the most likely diagnosis in this patient? Right. So it is the Budd-Chiari syndrome. It is your Budd-Chiari syndrome. So Budd-Chiari syndrome, the classical presentation will be the ascites, jaundice, and the abdominal pain. Right. These three are very important features in case of the Budd-Chiari syndrome. And basically, what is the problem in the Budd-Chiari syndrome? The problem in the Budd-Chiari syndrome is that there is obstruction in the hepatic veins, and this particular obstruction is caused by the thrombus. This obstruction is caused by thrombus, and because of that, the blood from the portal vein is not entering into the hepatic veins. So thereby what will happen? These patients will develop portal hypertension, and it's a post-hepatic cause for the portal hypertension. And because the venous blood is not able to enter into the hepatic vein, the liver get congested and there will be necrosis of the liver. And the type of the necrosis will be centrilobular necrosis. Now, what could be the etiologies that would be causing this Budd-Chiari syndrome? Basically, Budd-Chiari syndrome, what is the problem? Thrombus formation. Where all you can have thrombus formation? We have some hematological conditions like polycythemia vera and paroxysmal nocturnal hemoglobinuria. Then hypercoagulable states like protein C, proteinase deficiency. Then we have some drugs, oral contraceptive pills that too rich in estrogen can cause hypercoagulability. Tumors like hepatocellular carcinoma and renal cell carcinoma can cause the hypercoagulability, right? And then we have connective tissue disorders like APLA, where there will be hypercoagulability, where there can be formation of the thrombus within the hepatic veins. Okay, so this is about the etiology that will be causing the Budd-Chiari syndrome. Clinical features, just now I was telling you, this is a triad. What is a triad? Right upper quadrant pain, ascites, and hepatomegaly. These three are the triad in Budd-Chiari. Why there is jaundice in this patient? Because there is centrilobular necrosis. That is the reason why these patients have jaundice. And other features of the liver pathology, hepatorenal syndrome, pedal edema, all other features will be there. Now, the question is, how will you diagnose? The question is, how will you diagnose? The investigation of choice will be hepatic venography. Hepatic venography is the one which will show you that there is presence of the thrombus. And this patient has ascites. When you do an ascitic fluid tap and when you check the SAG value will be more than 1.1. And if SAG value is more than 1.1, that is suggestive of the portal hypertension. So then how do you treat these patients with the Budd-Chiari syndrome? The treatment of Budd-Chiari syndrome is, if it is acute form of Budd-Chiari syndrome, then you need to do the balloon angioplasty and anticoagulation therapy has to be given. But if it is the chronic form of the Budd-Chiari syndrome, then you need to do TIPS, that is transjugular intrahepatic portosystemic shunt has to be done. But if the patient is having ascites, okay, you need to give diuretics, that is spironolactone and all can be given. But because of this Budd-Chiari syndrome, the individual has gone into an end-stage liver disease. That is the point when you need to do orthoptic liver transplantation. That is the point when you need to do orthoptic liver transplantation. Chalo, this is about your Budd-Chiari syndrome, right? What is that you will remember in Budd-Chiari syndrome now? Thrombus in the hepatic vein, because of which portal hypertension, centrilobular necrosis. Okay, multiple etiologies are there. Clinical features, triad, right upper quadrant pain, ascites, and as well as hepatomegaly. Investigation of choice, hepatic venography. Acute cases, balloon angioplasty. Chronic cases, TIPS, transjugular intrahepatic portosystemic shunt. Done? Now, next important two topics. that is primary biliary cirrhosis and as well as primary sclerosing cholangitis, right? These are the two next topics. So first, let me discuss primary biliary cholangitis, then followed by the primary sclerosing cholangitis. Okay. Now, if you take this primary biliary cholangitis, let me tell you, it's an autoimmune condition and there is damage to the bile ducts. Which particular bile ducts are affected? That is mainly intrahepatic bile ducts are damaged, right? Small intrahepatic bile ducts are damaged. What is the HLA association? I don't know why in the recent times the examiners are becoming very much conscious on this HLA. In the recent exam also, there was a question on the HLA in the celiac disease, right? And please remember the HLA of the primary biliary cholangitis, that is HLA-DR-B1 and the HLA-DQ-B1. What will be the clinical manifestations? Liver is damaged, so metabolism does not occur, ATP synthesis does not occur. Thereby, these patients, they have fatigue. That is the earliest manifestation. And I have said you it is an autoimmune condition. So what should be the antibody? The antibody will be anti-mitochondrial antibody, right? And there are totally 4 stages in case of the primary biliary cholangitis. In stage 1, you have portal damage. And in stage 4, you have cirrhosis of liver. Then how do you work up? So if you see the workup in these patients, enzymes are elevated, SGOT, SGPT elevated. That will be there in any form of hepatitis. But what is a marker of the obstruction? The marker of the obstruction is the alkaline phosphatase levels are elevated. What is the investigation of choice? The investigation of choice will be the liver biopsy. Liver biopsy is the one which will give you the picture of the primary biliary cholangitis. What are the drugs that you should give in these individuals? Whenever you give this ursodeoxycholic acid, that will slow down the liver disease. But if suppose if the individual is intolerant to ursodeoxycholic acid, then you can give the obeticholic acid, right? And in these patients, the bile acids and as well as bile salts, they enter into systemic circulation and they are wasted out. So what is that particular drug which will cause the sequestration of the bile acids? That is the cholestyramine, right? Now, in refractory cases, what is that you need to do? What is the problem here? Antibodies, that is anti-mitochondrial antibodies. Now, these anti-mitochondrial antibodies have to be kicked out. What you should do or what you can do? Plasmapheresis. And the definitive treatment in these patients will be orthotic liver transplantation is what you need to do in case of the end-stage liver disease as a definitive treatment. That is about primary biliary cholangitis, right? What is the problem? Small intrahepatic bile obstruction. HLA, very important. DRB1, 08, DQB1. Earliest manifestation, fatigue. Investigation of choice, liver biopsy. Important molecule to be given, ursodeoxycholic acid. Refractory cases, plasmapheresis. Definitive treatment, orthotic liver transplantation. Done. Next, we'll move on to next topic, that is primary sclerosing cholangitis. Primary sclerosing cholangitis. In primary, what is the difference between these two is, in primary biliary cholangitis, it is only intrahepatic bile duct problem. Whereas in primary sclerosing cholangitis, it is both intra and as well as the extrahepatic bile duct problem. Okay. And these patients with the primary sclerosing cholangitis, they are at increased risk of cholangiocarcinoma. And please remember, this is a very important question, right? They are at increased risk of cholangiocarcinoma. What does the biopsy show? When you do a biopsy, you will have the onion skin fibrosis, right? The fibrous tissue is accumulated in the form of the whorls. And next important is the ERCP. Whenever you do ERCP, that is enteroretrograde cholangiopancreatography, ERCP will show you that there is beaded appearance. That is nothing but multiple strictures. What will be the clinical features in patients with primary sclerosing cholangitis? These bile salts and bipigments, they accumulate within the skin. And you also have some opioid intermediate products or opioid products that will be accumulated in the skin, and that will make the individual to develop pruritus. And these patients will have osteopenia due to vitamin D deficiency because the precursor of the vitamin D is synthesized in the liver. And how is that you will be testing for this? See, it is a marker of, it is a disorder of the obstruction. What are the markers for obstruction? Alkaline phosphatase levels are elevated and gamma GGT are being elevated. These two are the markers of the obstructive pathology which is being elevated, right? What is the investigation of choice? See, actually in primary biliary cholangitis, you can do biopsy. But here, the investigation of choice is MRCP, magnetic resonance cholangiopancreatography. Right? If at all, if you do liver biopsy, chalo, okay, you will have onion skin appearance. Right? Then, what is the treatment? You need to give ursodeoxycholic acid, which will slow down the progression of the liver pathology. And next important is you need to give or you need to do ERCP. But when will you do ERCP? If there is presence of large strictures which is causing severe symptomatic problem, in that you need to do ERCP. ERCP करके क्या करना है? You need to do balloon dilatation of the strictures. And followed by that, you need to do orthoptic liver transplantation when the individual has gone into a stage of end stage liver disease, right? So that is about primary biliary cholangitis and primary sclerosing cholangitis. So the difference is primary biliary cholangitis, only intrahepatic bile duct problem. Whereas primary sclerosing cholangitis, both intrahepatic and as well as extrahepatic biliary destruction. Okay, right. Regarding the jaundice, I'll not go into a detailed discussion. I'll tell you what are those three types of jaundice and what are the findings. That will be done regarding the jaundice. Okay, yes. Answer this question. Anyone? So match the following liver function test with their corresponding diagnosis. Right. So very good. The answer is C. Now, what are the three types of jaundice that can occur in adults? Hemolytic jaundice, hepatocellular jaundice, obstructive jaundice. You take the first scenario, that is in hemolytic jaundice. In hemolytic jaundice, the problem is before the liver. The problem is not within the liver, the problem is before the liver, where there is the excessive hemolysis, right? Where there is the excessive hemolysis. Now, in case of the hemolytic jaundice, the hemolytic jaundice, unconjugated bilirubin is being elevated because there is excessive hemolysis. And problem is not in the liver. That is the reason why SGOT, SGPT will remain normal. And even alkaline phosphatase levels also will be normal, because I have said you, alkaline phosphatase is a marker of the obstructive pathology in the liver. And in hemolytic jaundice, is there any obstruction? No. Isliye like the alkaline phosphatase levels will be normal. So in hemolytic jaundice, it is only unconjugated bilirubin that will be elevated. SGOT, SGPT will be normal and alkaline phosphatase normal. Hepatocellular jaundice. Hepatocellular jaundice. In hepatocellular jaundice, the problem is within the liver. So bilirubin elevated, SGOT, SGPT elevated, alkaline phosphatase normal, or there may be mild rise. Because in hepatocellular jaundice, you don't have the problem of obstruction. That is the reason why alkaline phosphatase levels will remain normal. Obstructive jaundice, where there is an obstruction. So in any form of jaundice, definitely bilirubin is elevated. Only in case of hemolytic jaundice, unconjugated bilirubin will be elevated. But in hepatocellular and obstructive jaundice, the problem is within the liver and outside the liver. So the conjugated bilirubin will be elevated. And in obstructive jaundice, the problem is outside the liver, not within the liver. So that is the reason why SGOT, SGPT levels will remain normal. But what is being elevated? The alkaline phosphatase and as well as the gamma GGT, right? Gamma GGT, that will be elevated in case of the obstructive jaundice. So very simple to define to make out the jaundice. Hemolytic jaundice, unconjugated bilirubin elevated, remaining everything normal. Hepatocellular jaundice, bilirubin elevated, conjugated, SGOT, SGPT elevated, alkaline phosphatase normal. Obstructive jaundice, conjugated bilirubin elevated, SGOT, SGPT normal because the problem is outside the liver, and the obstructive pathology, that is alkaline phosphatase and gamma GGT, is elevated. So these three things, if you know related to the jaundice, that is more than enough, right? And if you want to have a detailed discussion of the jaundice, right, I have provided this in the PDF, and you can go through this in the PDF as well, right? Right. So as I have already said you, the PDFs are available on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. Done. Now, the next topics for the discussion are the Wilsons and as well as the hemochromatosis. Chalo, answer this question, guys. Liver biopsy for copper will be stained by which of the following stain? Actually, it's an integration. Pearl stain, Rubianic stain, supravital stain, Schmoll's method. Very good. So, for liver biopsy, for copper, the stain that we use is the Rubianic acid. That is Rubianic acid. Okay. Whereas the pearl stain, that is for the iron deposits. That is for iron deposits. And you take the supravital stain, that is used in microscopy to observe the cells of living organisms. Right? To observe the cells of living organisms, you need to do supravital staining. Next is the Schmoll's method. Schmoll's method is mainly to detect the melanine. Mainly to detect the melanine. Okay. So that is about, yeah, hemochromatosis, it is pulse. Hemochromatosis, it is pulse. Okay. Now, let us do the detailed discussion of Wilson's and as well as the hemochromatosis. So, what is that very commonly asked in case of Wilson's? Gene mutation. What is the gene that is being mutated? The gene that is being mutated is the ATP7B gene that is being mutated, and on which chromosome it is present? It is present on chromosome number 13. And how is it being inherited? It is being inherited as the autosomal recessive type of inheritance. Now, because of this gene problem, what is being deficient? Ceruloplasmin is being deficient. And because the ceruloplasmin is being deficient, what is the problem? The copper will go and accumulate in various parts of our body. That is liver, brain, kidney, and as well as eyes. Multi-system involvement will be there in case of Wilson's. And accordingly, what will be the individual organ involvement? Okay. So liver problem is like hepatitis and cirrhosis of liver. Mainly in case of Wilson's, you will have macronodular cirrhosis. Right? So you will have macronodular cirrhosis. Neurological, your copper will go and accumulate within the basal ganglia or in the extrapyramidal systems. That is the reason why these patients will have tremors, dysarthria. Psychiatric manifestations in the form of emotional instability. The copper can also go and accumulate within the kidney, resulting in Fanconi's syndrome. What is Fanconi's? Anyone, guys? It is type 2 renal tubular acidosis. Within the eye, copper can accumulate, resulting in the KF ring, or the KF ring will be there within the Descemet's membrane of the cornea. How will you evaluate these patients? You need to do a first line investigation is 24-hour urinary copper. That will be more than 100 micrograms per day. Right, more than 100 micrograms per day. And what are the other investigations? Liver biopsy, if you do, the hepatic copper will be more than 250 micrograms per gram of dry weight. And ceruloplasmin levels are decreased. That is a problem in Wilson's due to the ATP7B gene mutation. MRI, face of panda sign. Genetic testing is the one which will confirm that it is Wilson's, where you have a problem in ATP7B, right? Now, can anyone tell me differential diagnosis for face of panda? Differential diagnosis for face of panda sign. Anyone? So the face of panda is observed in case of the sarcoidosis. So in sarcoidosis, you will have this face of panda sign. That is in gallium uptake studies. I'm not talking about MRI head. In gallium uptake studies, you will have the face of panda sign in sarcoidosis. Okay? Then, how do you treat these patients with the Wilson's? So you need to give zinc acetate. What the zinc acetate will do? It will inhibit the copper absorption. What are the alternative molecules? The alternative molecules are trientine and as well as dipencilamine. Trientine and dipencilamine, they are given mainly in a state of the decompensated cases. Mainly in decompensated cases. Then, next important is when the individual develops severe disease. Now, this is a question here. What is the index that we use for Wilson's? That is Naser score. And if this Naser score is more than 9, that is the point when you need to do the orthoptic liver transplantation. Done. So this is about your Wilson's. So regarding Wilson's, what is the questions now? Gene, ATP7B gene. Which chromosome? Chromosome 13. Inheritance, autosomal recessive type of inheritance. What is the problem? Ceruloplasmin being deficient. What are the organs affected? That is liver, kidney, brain, eyes. Right? And accordingly, you have the manifestations. Type of cirrhosis, macronodular cirrhosis. Within the eye, KF ring. Within the kidney, Fanconi syndrome. Within the brain, resting tremors and extrapyramidal side effects. Workup, 24-hour urinary copper. Confirmation by genetic testing. MRI head, face of panda sign. Treatment, zinc acetate. Mechanism, inhibits the copper reabsorption. Right? That is about the Wilson's. Next topic is the hemochromatosis. This is the last topic in the hepatology. This is the last topic in the hepatology. So, in case of the hemochromatosis, that is also again due to gene abnormality. What is the gene that is being defective? The HFE gene is being mutated, where there was ATP7B gene, which was present on chromosome 13. Whereas here, it is HFE gene which is present on the chromosome 6. Type of inheritance, autosomal recessive type of inheritance. And because of this HFE gene mutation, what is the problem? The problem is there is unregulated iron absorption. There is excessive iron absorption, and that iron will go and accumulate within the liver, pancreas, heart, skin, and as well as the joints. And what is the organ that is affected first? That is liver. Liver is the first organ that is being affected. What is the first line investigation? You need to check the transferrin saturation. So what will happen to the transferrin saturation? That will be more than 45%, and that is the first line investigation. And you take this multi-system involvement. So liver involvement will be in the form of cirrhosis, but here it is micronodular cirrhosis in hemochromatosis, whereas in Wilson's it is macronodular cirrhosis, right? And regarding the pancreas, like bronze diabetes mellitus. Regarding the heart, there will be development of the cardiomyopathy, right? That is, what type of cardiomyopathy in hemochromatosis? Anyone? What type of cardiomyopathy you will have in hemochromatosis? So it is both. Restrictive cardiomyopathy can be there, and as well as dilated cardiomyopathy can also be there in case of the hemochromatosis, right? That is the heart. Skin, that will be in the form of hyperpigmented skin. Bronzing of the skin will be there. And which particular joints are affected? That is second and third metacarpophalangeal joints. And I said you, like the first line investigation is what? That is the transferrin saturation will be more than 45%. And the investigation of choice will be liver biopsy. Liver biopsy will show you that the hepatic iron index is more than 2. And how will you confirm the diagnosis? That is by genetic testing, where you will have the HFE mutation, right? And the first line treatment will be what? Phlebotomy. By doing phlebotomy, you will be taking out the excess iron. But if there is anemia, you cannot do phlebotomy. Whenever there is anemia, then what is that you need to do? You need to do the iron chelation. That is, iron chelation can be done with the deferoxamine and as well as deferoxyrox. Okay, so this is about the hemochromatosis. So what are the important points? Gene mutated is HFE gene mutation, which is present on the chromosome number 6. The first organ that is affected is liver. That will be in the form of your micronodular cirrhosis. And the first line investigation will be transferrin saturation. Investigation of choice will be liver biopsy, and first line treatment will be phlebotomy. So this is about the story related to the hemochromatosis, and this is the story related to the hepatology as well. Yes, please tell me, how was the session until hepatology? Yes, how was the session until hepatology? Anyone? Great. So now, what is the next topic? The next topic for the discussion, connective tissue disorders. Right, the next topic for the discussion will be connective tissue disorders. Okay, just give me a minute. Yes. Right. Now, so if you take this connective tissue disorders, what is the topic first I'll be discussing? Just 1 minute. Okay. So in the connective tissue disorders, yeah, today I will try to cover this hepatology, then connective tissue disorders, plus or minus nephrology and endocrine. Plus or minus. It all depends upon the number of students who will be there online. Because if more number of students are there, it will be encouraging for me. Definitely I'll be doing more systems. If number drops down drastically, right, I will not have any encouragement to continue the class. Okay? Chalo. And it also depends on me how I am engaging you. That is also the the tagline mark. Chalo. Right. Please answer this. Which clinical manifestation will be present in a patient like with likely rheumatoid arthritis and enlarged spleen? Lot of disturbance on the background. There's nothing actually. It's like a completely quiet room. Only AC is switched on. That's all. No, the answer is not A. The answer is not A. So, what exactly is this? The patient is having enlarged spleen and the patient is having rheumatoid arthritis. This particular syndrome, it is Felty's syndrome. This syndrome is the Felty's syndrome. Now I have given you a clue. Very good. So the answer is neutropenia. The answer is neutropenia. What is this? It's a Felty's syndrome. So in Felty's syndrome, what is that? You will have rheumatoid arthritis, splenomegaly, and as well as neutropenia. Right? And when will this new Felty's syndrome develops in rheumatoid arthritis patient? Felty's syndrome occur in chronic patients of rheumatoid arthritis. Like basically after 10 to 15 years of onset of the rheumatoid arthritis, there can be development of this Felty's syndrome, right? And if the patient with rheumatoid arthritis is treated aggressively with DMARDs, the chances of developing Felty's syndrome will be very negligible. Okay, Chalo. So are you all ready for the rheumatoid arthritis quick revision? Right. As already I have said you guys, those students who are joining new, the PDF of this particular topic is available on my Telegram channel. That is Medicine Made Easy by Dr. Rajesh Gubba. So you can download this PDF from this my Telegram channel. And if you're all liking my sessions, you can follow me on my Instagram, that is Rajesh Gubba, where you can have the clinical material every day related to general medicine. Right. Now, starting with the session, first and foremost, the definition is, what is this basically? It's a chronic inflammatory disease. And in this chronic inflammatory disease, the joints which are commonly affected is small joints are being affected. Small joints are affected, and that too symmetrical involvement. Symmetrical involvement. And it's an autoimmune condition, guys. So because it's an autoimmune condition, it is very common in women rather than men. What is the age group at which you see this rheumatoid arthritis? This is very common in the age of 4th to 5th decade. Very common in 4th to 5th decade. And in the pathogenesis, please remember, it is not just only the bone which gets affected in rheumatoid arthritis. It involves both the cartilage and as well as bone. So there is erosion of the bone and erosion of the cartilage. And the key symptoms in these patients will be morning stiffness. And this morning stiffness will be there for more than 1 hour. Whereas you take in osteoarthritis also, there will be morning stiffness, but this morning stiffness in osteoarthritis will be less than 1 hour. That is the important difference in the morning stiffness of rheumatoid arthritis and osteoarthritis. Okay. Now, what are the other features apart from morning stiffness within the small joints? So what are the joints which are affected in this? That is the PIP, MCP, and MTP. What is that particular joint which is not affected? that is DIP is not affected. But in which conditions the DIP is involved? Then DIP is involved in case of the osteoarthritis as well as the psoriatic arthritis. Osteoarthritis and psoriatic arthritis. Okay. Now, and in these individuals, as the time passes, in these individuals, as the time progresses, background team of Prosium, right? Those who are operating this, your voice is disturbing a lot. Please don't talk. Backend team, please don't talk. It is disturbing the session. Right. Now, coming to the deformities. So now the deformities that you observe in these patients with the rheumatoid arthritis is you have swan neck deformity and as well as the boutonniere's deformity. Right, these two are the important deformities. And another important deformity that you will have is the ulnar deviation, right? Ulnar deviation, and you also have the presence of the Z-shaped thumb. You will also have the presence of Z-shaped thumb. So these will be the deformities that you will have in patients with the rheumatoid arthritis. And in rheumatoid arthritis, do you have spine involvement? Yes, spine involvement also will be there. And that is mainly cervical spine, that is C1 and C2. And whenever there is spine involvement, there will be atlantoaxial dislocation resulting in quadriparesis. Okay. And what is the most common extra-articular manifestation? The most common extra-articular manifestation, that will be subcutaneous nodules, and these subcutaneous nodules will be there over the extensor aspect of the forearm, and these subcutaneous nodules, they're painless. They're painless, and multiple systems are affected. Lung involvement can be there in the form of pleural effusion and interstitial lung disease, and the eye involvement can be there in the form of scleritis, and cardiac involvement can be there in the form of pericarditis. So please remember, in case of rheumatoid arthritis, it is not only articular, there will also be extra articular manifestation as well. Then how is that you will do workup in patients with the rheumatoid arthritis? So the workup is you have one non-specific investigation. What is that non-specific investigation? RA factor. But this RA factor is positive in multiple conditions, not only in rheumatoid arthritis. Then what is the investigation of choice, which is like more specific? The more specific investigation will be the anti-CCP. Anti-CCP is the more specific investigation in case of the rheumatoid arthritis. Now, whenever you are treating these patients, what is that you should focus on? You should focus on reducing the inflammation and preventing the deformity. So in acute cases, you can give NSAIDs and as well as steroids, but as a part of the maintenance, the drugs that you should give is the DMARDs, disease modifying anti-rheumatic drugs. And in this disease modifying anti-rheumatic drugs, what is the drug of choice? The drug of choice will be methotrexate. Methotrexate is considered as the drug of choice, right? And these are non-biological DMARDs. These are non-biological DMARDs: methotrexate, sulfadiazine, leflunomide, and hydroxychloroquine. And what are the biological DMARDs? The biological DMARDs will be the TNF alpha inhibitors, abatacept, rituximab, and Janus kinase inhibitors, that is tofacitinib, tofacitinib, and then baricitinib. These two are Janus kinase inhibitors, right? And we were discussing about the complications, that is cardiovascular disease. If at all, if there is death in patients with rheumatoid arthritis, it is mainly because of the cardiovascular abnormality. It is mainly because of the cardiovascular abnormality. So this is about your rheumatoid arthritis. So quickly, what is the problem here? Chronic inflammatory disease, symmetrical polyarthritis, small joints are affected, more common in women, right? And there will be morning stiffness that will be there for more than 1 hour. Small joints which are affected is PIP, MCP, MTP. DIP is not affected. Cervical spine is involved. Atlantoaxial joint dislocation. Most common extra-articular manifestation will be subcutaneous nodules. The most specific investigation will be anti-CCP. Treatment should be the anti-inflammatory drug, and you need to prevent the deformities. You need to give DMARDs. And that particular DMARDs will be methotrexate is a drug of choice. And in refractory cases, you need to start the biological DMARDs. And the cause of death will be cardiovascular abnormality. Done. Your rheumatoid arthritis is over. Now, coming to the next topic, that is the ankylosing spondylitis. Okay, chalo. You please see this question and answer this. We have a 28-year-old man presents to the clinic with complaints of the low backache persisting for past 3 months. Which of the following statement regarding presentation of the back pain is appropriate? Low back pain persisting for past 3 months. Which of the following statement regarding the presentation of the back pain is appropriate? So low backache for 3 months, and that too in an age of 28 years. So definitely you need to think of the ankylosing spondylitis. So, right. So Anash has answered it correctly and Kashmiri has answered it correctly. That is, pain in neurogenic claudication, it worsens with standing. Pain in neurogenic claudication, it worsens with standing, and also it worsens with walking. Also it worsens with walking, right? And back pain in sciatica and disc prolapse is diurnal? No, it's a wrong statement. Back pain in sciatica, it increases with activities like bending, lifting, and as well as the prolonged sitting. Whereas pain in Berger's disease, which is nothing but thromboangiitis obliterans, it typically worsens at night. So please remember, in case of the Berger's, the pain will get increased on exposure to the cold temperature. It is not specifically noted to worsen at night. That is your Berger's disease. Then you take the last option. That is, pain relief is typically observed with use of gabapentin or pregabalin in case of the ankylosing spondylitis. It's a wrong statement. What we give in case of ankylosing spondylitis, it is indomethacin, not this pregabalin or gabapentin. So the correct answer here is second option, pain in neurogenic claudication worsens with standing. Okay, right. Now we will do the detailed discussion of the ankylosing spondylitis. Detailed discussion of the ankylosing spondylitis. Okay, right. What is this ankylosing spondylitis? Please remember, ankylosing spondylitis is also a chronic inflammatory disease. Which part of the body is affected in ankylosing spondylitis? That is, the axial skeleton is commonly affected, right? Where you have the abnormality within the spine and as well as the sacroiliac joints. These two are the common organs which are affected in case of the ankylosing spondylitis. Okay. Now, this ankylosing spondylitis, it is a part of the seronegative arthritis. Now, what are the other examples of seronegative arthritis? Please remember this mnemonic, that is PAIR. What is this PAIR? P stands for psoriatic arthritis. A stands for ankylosing spondylitis. I stands for inflammatory bowel disease. R stands for the reactive arthritis. Okay. Now, what are the associations? Please remember, the association of the ankylosing spondylitis, it is with the HLA-B27. And what is the age of onset? Around the age of 40 years. And it is very common in adolescence or the early adulthood. What is the important symptom in patients with ankylosing spondylitis? That will be low back pain. Low back pain is a very important symptomatology. And this particular low back pain will be there for nearly around 3 months. Will be there for nearly around 3 months, right? And along with that, the other features that you will have is morning stiffness, reduced spine mobility. Why there is reduced spine mobility? Because there is fusion of the vertebra. That is the reason why you have reduced spine mobility. Now, what is the test that we do for assessing the spine mobility? The test that we do for assessing the spine mobility is the Schober's test. And the Schober's test will tell you that there is restricted spine mobility. And not only that, in these individuals, there will be restricted chest expansion. And what is the most common extra-articular manifestation? The most common extra-articular manifestation in ankylosing spondylitis will be anterior uveitis. And apart from anterior uveitis, the other features that you will have is enthesitis. And in the heart, there will be aortic regurgitation or aortic insufficiency. And these patients can also develop the complete heart block. And that is because of the AV nodal block. That is an ankylosing spondylitis, right? And what will be the radiological features? Radiological features of ankylosing spondylitis has been asked multiple times. So when you do X-ray of the spine, you will have the bamboo spine. And there is pseudo widening of the joint spaces. Pseudo widening of the joint spaces. There will also be squaring of the vertebra. And whenever you do an MRI, MRI will show you that there is the bone marrow edema. MRI will show you that there is bone marrow edema. That will be the radiological finding in patients with the ankylosing spondylitis. And extra-articular manifestation, just now I have said you, anterior uveitis is the most common extra-articular manifestation, right? Then how is that the workup that you will do in patients with ankylosing spondylitis? As I have already said you, the HLA-B27 will be positive. right? And you have the characteristic X-ray and MRI finding. What is that X-ray finding? One is your bamboo spine, right? One is your bamboo spine, pseudo widening of the joint spaces, squaring of the vertebra, and MRI will be showing the bone marrow edema. MRI will be showing bone marrow edema. And what is the name of the diagnostic criteria? That is ankylosing spondylitis criteria, in which you should have HLA-B27 positive. Along with HLA-B27 positive, there should be imaging and as well as the clinical features of the spondyloarthritis. What is the imaging features? Same, bamboo spine, squaring of the vertebra, pseudo widening of the joint spaces, right? What is that you'll have in MRI? MRI will show you bone marrow edema. So that should be there on the imaging. What will be the clinical features? That will be low back pain. That will be low back pain. Okay. Then what is the drug of choice? Drug of choice will be indomethacin. That is a drug of choice, right? And whenever you're giving indomethacin, the individual should clinically improve. So what is that particular tool which will assess the disease activity? The tool which will assess the disease activity is the BASDI index. That will give you the important methodology of assessing the disease activity. Now, if you are giving indomethacin, but if your BASDI index is like score is more than 4, that will tell you that the disease is, the individual is having a poor disease control. Now, from the indomethacin, right, from indomethacin, you need to shift to the anti-TNF agents. From the indomethacin, you should give the biologicals, and this particular biologicals will be anti-TNF agents. These biologicals will be anti-TNF agents. Okay, next. What is the complications? The complications that you will have is the spinal fusion. I said you already, the vertebra will be fused. Cardiovascular abnormality can be there in the form of aortic regurgitation and complete heart block, and there will be reduced quality of life. There will be reduced quality of life. Okay, so this is about the ankylosing spondylitis. So to quickly summarize ankylosing spondylitis, chronic inflammatory disease, spine and sacroiliac joint is commonly affected, right? And seronegative arthritis, please remember the mnemonic pair. And your ankylosing spondylitis is also seronegative arthritis. That means RA factor will be negative. And the key association will be the HLA-B27, right? HLA-B27 will be positive. Age of onset, around 40 years. Key symptoms, inflammatory back pain, low back pain, and loss of spinal mobility. How will you test for reduced spinal mobility? Schober's test, right? Then radiology, X-ray will show you bamboo spine. MRI will show you bone marrow edema. And extra-articular manifestations, most common, anterior uveitis. Investigations, HLA-B27 being positive, right? And treatment, indomethacin is the drug of choice. In refractory cases, you need to give the anti-TNF agents. How will you test the refractoriness? BASDI index. Complications, complete heart block and aortic regurgitation. Done. This is about your ankylosing spondylitis. Yes. So how is the session going on? Please just give me, please motivate me, please encourage me by giving some love and as well as affection. Right. So because continuously speaking, it is not that easy to continuously speak. Actually, in face-to-face classes, what will happen is we will have some time to wait because we will be interacting in face-to-face classes. You will have some voice rest, like at least, some seconds also you'll get some voice rest. But in this particular online sessions, it becomes very difficult. You will not have the voice rest continuously. And that too, it's a, rapid revision. I should continuously talk. Immediately, I should finish the portion. Hello. Right. So coming to the next topic, that is the Ritter syndrome or the reactive arthritis. Right. So Ritter syndrome or the reactive arthritis. Right. Ritter syndrome or the reactive arthritis. So what exactly is the problem here? Ritter syndrome or reactive arthritis, it's also a seronegative arthritis. It is characterized by a triad. What is the triad? That is urethritis, arthritis, and as well as the conjunctivitis. Urethritis, arthritis, and conjunctivitis. Okay, these three are the triad. And in order to develop this Ritter's or reactive arthritis, there should be a background history. What should be that background history? The individual should be having either gastrointestinal or the individual should be having a genitourinary infection. Right. And what is this gastrointestinal infection caused by? Gastrointestinal infection is caused by Shigella, Salmonella, and Campylobacter. Genitourinary infection is caused by the Chlamydia trachomatis. And what is the most common organism? that will be causing your reiters or reactive arthritis, that is chlamydia trachomatis. Okay, that is the most common organism. Done. Then HLA, as already I have said you, HLA, as already I have said you, it is the HLA-B27 that will be positive. HLA-B27 that will be positive, right? And okay, so in between the ads are the one which are little demotivating. Chalo, theek hai. Right. Then next is the epidemiology. So please remember, this is more common in men than compared to that of the women. So what is the important part of your arthritis? It is not polyarthritis, it is oligoarthritis. It is oligoarthritis, followed by that enthesitis, very important cutaneous manifestation, that will be keratoderma blennorrhagica, right? Keratoderma blennorrhagica. What is keratoderma blennorrhagica? Keratoderma blennorrhagica is the presence of the keratotic vesicles, hyperkeratotic lesions over the palm and sole of the foot. That is called keratoderma blennorrhagica. So these are the key symptoms in case of the reiters or the reactive arthritis. So how will you diagnose reiters or reactive arthritis? You need to do the culture, right? You need to do culture from urethra, cervix, throat, and culture of the urine and as well as stool. HLA-B27 is the one which will be positive, right? And now, if you take the arthritis here, asymmetrical arthritis, whereas in rheumatoid arthritis we have discussed symmetrical polyarthritis, whereas here asymmetrical oligoarthritis, that is very, very important. And what is the treatment that you will give for arthritis? That is NSAIDs has to be given. And it is secondary to infection, right? So you need to give the antibiotics. Okay, but antibiotics are effective only in acute infections, right? Antibiotics are effective only in acute infections. Okay. Then next, followed by that, the DMARDs. And these DMARDs, that is your sulfasalazine or the methotrexate for NSAID resistant cases. That means if the patient is not responding to NSAID, then you need to give DMARDs like methotrexate or sulfadiazine. Okay. And in refractory cases, you need to give the rituximab, that is an anti-TNF agent. Right? Skin manifestations are asked as multiple choice questions. And what is that skin manifestation? That is keratoderma blennorrhagica. Keratoderma blennorrhagica. Okay. And this is the important points related to reiters or reactive arthritis. Chalo? Right. 1 मिनट में रिवाइज करता हूं मैं. So reiters are reactive arthritis, triad, urethritis, arthritis, conjunctivitis. Background history: gastrointestinal, genitourinary infection. Gastrointestinal: Shigella, Salmonella, Campylobacter. Genitourinary: Chlamydia trachomatis. More common: Chlamydia trachomatis. HLA-B27 positive, right? And this arthritis is oligoarthritis, and that too asymmetrical oligoarthritis. Skin manifestation: keratoderma blennorrhagica. Diagnosis by culture and HLA-B27 positive. Then the treatment, NSAIDs, and antibiotics should be given. Refractory cases, the sulfadiazine and methotrexate. And not responding, you can give anti-TNF, right? And prognosis, it usually resolves. Good prognosis. So that is about reiters or reactive arthritis. Done. Chalo. The next topic is systemic lupus erythematosus, which is a very, 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 very important topic, right? So yes, you please see this question. You please do this question. I'll be back in a minute. 1 minute, I'll be back. You please go through this question and do this question. Chalo, I'm back. So what is the answer here? Which of the following statement about the specific autoantibody in SLE is incorrect? First of all, what is the most specific antibody about the specific autoantibodies in SLE is incorrect? Okay. So what is the first option? Anti-Smith antibody is highly specific for the SLE. That is correct. Okay. And anti-Ro antibody is associated with photosensitivity and complete heart block in fetus. Correct. Then anti-dsDNA, it correlates with the disease activity in SLE. Correct. Then anti-lupus anticoagulant decreases the risk of the nephritis in SLE. That is the incorrect statement. So please remember this anti-lupus anticoagulant, it increases the risk of thrombotic events. Right? It increases the risk of the thrombotic events. Okay. Now, because it increases the risk of thrombotic events, the individual will have recurrent abortions, particularly in females. And it also increases the risk of nephritis. Right? It also increases the risk of nephritis in patients with the SLE. Okay. So this is about the serology. Serology is very important in SLE. Serology is important in two scenarios. Number one, hepatitis B. वो serology revise करके ही जाना hepatitis B serology. Number two, SLE. SLE serology antibodies you should revise and go before the exams. I'll give you a table, right? So this table, so I'm repeating once again, this PDF is available on my Telegram channel. That is Medicine Made Easy by Dr. Rajesh Gubba. You can join and download this PDF. Right. So the antibodies, anti-nuclear antibody, it is highly sensitive. Anti-Smith, more specific for SLE. Anti-dsDNA, it will correlate with the disease activity. Anti-Ro antibody, which is responsible for the photosensitivity. And it will also cause the complete heart block. And the other condition where you will have anti-Ro, that is Sjogren's syndrome. Anti-lupus anticoagulant, there is increased risk of nephritis and increased chance of abortion. Anti-histone antibody, drug-induced lupus, and prognosis is better. Next, antiphospholipid antibody, these individuals, they are at increased risk of the abortions. Then anti-erythrocyte antibody, it is associated with the development of anemia and as well as the autoimmune hemolytic anemia. Anti-platelet antibody, this will be causing thrombocytopenia. Anti-neuronal antibody, this can cross the blood-brain barrier and this will cause the cerebral edema. That is anti-neuronal antibody, right? And this anti-glutamate antibody, it is also the one which is associated with the CNS manifestations. Anti-ribosomal P antibody associated with psychosis in SLE. Anti-ribosomal, that is anti-RNP, that is anti-ribonucleoprotein antibody, that is in MCTD, that is mixed connective tissue disease. And this MCTD is not related to your SLE. What is MCTD? In MCTD, not only SLE, multiple other connective tissue disorders will be there in case of MCTD, right? So this is about the serology or the antibodies in case of the SLE. Chalo. Right, shuru karenge. We will start with the SLE discussion. So in the SLE, what exactly it is? It is an inflammatory autoimmune disorder where you have autoantibodies. These autoantibodies are formed against the nuclear and as well as cytoplasmic components. And within the various systems, what are actually accumulated is the immune complexes are accumulated. And these immune complexes, they will cause damage to the systems. That is the reason why it is considered as a type 3 hypersensitivity reaction. What is the most common symptomatology in these patients? Most common symptomatology will be fatigue, malaise, fever, arthralgia. These will be the key symptoms, right? Then, what are the skin manifestations? Skin manifestations will be in the form of malar rash, where there is fixed erythema over the malar eminences and sun-exposed areas. There is also discoid rash, where you have erythematous circular raised patches with scaling. There is also photosensitivity, right, where you have rash triggered by sunlight exposure. And there is also the oral ulcers, and they are painless oral ulcers. And if you take the organ involvement, right, multiple systems are affected: skin, joints, kidneys, heart, lung, CNS, blood, everything is affected. What is that kidney involvement? That kidney involvement will be in the form of lupus nephritis. And there are totally 6 classes of lupus nephritis. But among all these, which is the most severe form? The most severe form is class 6, which is nothing but diffuse lupus nephritis. What is the characteristic biopsy lesion in case of lupus nephritis? That is the wire loop lesions. What are the cardiac manifestations? Pancarditis, pericarditis, myocarditis, endocarditis will be there. But which is more common? Pericarditis is more common. What will be the endocardial involvement? That endocardial involvement is Liebman-Sachs endocarditis, right? Where there is valvular involvement. And these patients, they are at increased risk of atherosclerosis and vasculitis. Pulmonary manifestations, if you see, that will be in the form of the pleuritis. That will be the most common manifestation. And that can result in the development of the pleural effusion. And there will also be development of what is called the shrinking lung syndrome. What is this shrinking lung syndrome and why is this due to? This is due to antibody formation against the diaphragm. Right? Antibody formation against the diaphragm. And this antibody which is formed against the diaphragm will cause the diaphragmatic paralysis. And that will cause the shrinkage of the lung. That is called shrinking lung syndrome. But this is a rare manifestation. What will be the CNS manifestation? That will be in the form of the seizure, psychosis, and cognitive dysfunction, right? And the antibodies which are associated with the CNS abnormality, that is anti-RNP antibody and anti-neuronal antibody. And hematological, already I have discussed, that is autoimmune hemolytic anemia, thrombocytopenia will be there. And APLA syndrome, that is the hypercoagulable state. Immunological markers, already I have discussed, I am not repeating here. But very important thing, what I want to tell you is about the drug-induced lupus. What is the most common drug? The most common drug will be procainamide, which is class 1 anti-arrhythmic drug. What are the other drugs that will be causing drug-induced lupus? Hydralazine, which is an antihypertensive, which is an arteriolar vasodilator. Isoniazid, which is an anti-tubercular drug. And this drug-induced lupus will resolve by stopping the drug. What is the name of the criteria for the SLE? The name of the criteria will be the EULAR or the ACR criteria. What will be there in this EULAR or ACR criteria? There should be a combination of the clinical and the immunological finding. And that immunological finding includes ANA, anti-dsDNA, and specific organ involvement. What is the treatment in these patients? Common presentation will be in the form of arthralgia. So in mild cases, you can give NSAIDs and as well as hydroxychloroquine. But in moderate to severe cases, they will be requiring the immunosuppressive agents like glucocorticoids. And the other immunosuppressive agents which can be given is mycophenolate mofetil and as well as cyclophosphamide. And if at all, if there is cutaneous involvement, for that you need to give the hydroxychloroquine and you should avoid the sun exposure. And in refractory cases, corticosteroids have to be given. And if at all, if there is CNS involvement, you need to give antipsychotics and as well as steroids. And overall, what is the cause of death in these patients? Overall, the cause of death in these patients with the SLE will be infections, and that is because of neutropenia. And in early stages of SLE, the cause of death could be even due to renal failure. And in the later stages of the SLE, the cause of death can be even the thromboembolic events as well, right? And these patients, there is increased risk of premature atherosclerosis that will result in the coronary artery disease. So this is about your SLE. SLE is done in just 5 minutes. Okay. So now in 1 minute, I will revise. So it is an autoimmune condition, type 3 hypersensitivity reaction, right? Common manifestations will be like fatigue, malaise, fever, arthralgia, skin manifestation, malar rash, discoid rash, photosensitivity, and oral ulcers. Kidney involvement in the form of lupus nephritis, class 6, which is the most, class 4, which is like most severe form, wire loop lesions. Cardiac manifestations, pancarditis, most common is pericarditis. Pulmonary involvement, pleuritis, pleural effusion, rare manifestation will be shrinking lung. CNS manifestations, seizure, psychosis. Hematological abnormality, autoimmune hemolytic anemia, neutropenia, and thrombocytopenia. Immunological markers, most sensitive, ANA, most specific, anti-Smith, the one which will tell you about the severity, anti-dsDNA. Drug-induced lupus, most common drug, procainamide, anti-histone antibody. Name of the criteria, EULAR or ACR criteria. Mild cases, NSAIDs and hydroxychloroquine. Moderate to severe cases, glucocorticoids. Cutaneous manifestations, hydroxychloroquine. right? CNS, you need to give the antipsychotics. Overall cause of death, the infections. Okay, so this is about your SLE. SLE is over. Coming on to the next topic for the quick revision, that will be the Sjogren syndrome. That will be Sjogren syndrome, right? So yes, please attempt this question related to Sjogren's. I'll get little voice rest. At least for 10-20 seconds, I will take voice rest. Please answer this question. Right. So basically the entire clinical scenario which is being given where there is dry eyes and dry mouth, and there is episodes of gritty sensation in her eyes, difficulty in swallowing. So dry eyes and dry mouth. Suggestive of Sjogren's. What is the HLA association? So the HLA association in case of the Sjogren's, it will be HLA DR3, DRW52. That is a HLA association in case of the Sjogren's. Okay. So now, in case of the Sjogren's, this is also an autoimmune condition, right? So this is also a systemic autoimmune disorder. Where is the problem? Eyes and oral cavity. So dry eyes and as well as dry mouth. Dry eyes and dry mouth. Autoimmune condition. So it is common in women rather than men. What is the age group at which you see this commonly? 40 to 60 years of age. And because it's an autoimmune condition, the gland is infiltrated by the lymphocytes. And what is that lymphocytes? CD4 plus T lymphocytes, right? And that particular lymphocytes will produce the antibody that is anti-Rho and anti-La antibody. And this particular Sjogren's, it is of two forms, primary and secondary Sjogren's. Primary Sjogren's is that only Sjogren's, that is called Sika syndrome. Secondary Sjogren's is that along with Sjogren's, you have other associated autoimmune conditions like rheumatoid arthritis, SLE, scleroderma, and primary biliary cholangitis. This is what is nothing but your secondary Sjogren's. Then, what are the important symptomatologies that you will have in case of Sjogren's? That will be in the form of dry eyes and dry mouth, and parotid gland enlargement will be there in 50% of individuals due to infiltration of the lymphocytes. And there is also difficulty in swallowing the dry food, dental caries, and in females, they will have dry vagina. And that is due to damage to, or that is due to destruction of the Bartholin's gland, and thereby they will have very painful sexual intercourse, and that we call it as dyspareunia, right? Then, apart from glandular, you also have extraglandular. What is the most common extraglandular manifestation? That will be in the form of arthritis. The other extraglandular manifestations will be in the form of Raynaud's, vasculitis, and then the peripheral neuropathy. Apart from this, these patients will also develop type 1 renal tubular acidosis and as well as the interstitial lung disease. Very important question is that these individuals, they are at increased risk of development of lymphoma. What type of lymphoma is commonly observed in these patients? That is low-grade marginal B-cell lymphoma, right? Low-grade marginal B-cell lymphoma. And autoantibodies, mainly anti-Rho and as well as the anti-La. So how will you diagnose this? So diagnosis is by your Schimmer's test that will demonstrate the tear secretion is reduced. Cylometry that will demonstrate the salivary secretion is reduced, right? Where there will be salivary secretion less than 1.5 ml in 15 minutes, that is considered to be positive. And the confirmation can be done by the labial biopsy. Labial biopsy will show you that there is lymphocytic infiltration, which is most sensitive and as well as specific test for Sjogren's, right? And differential diagnosis, what is the other condition where you have the enlargement of the parotid gland is in sarcoidosis. And that syndrome is called uveoparotid syndrome, or we call it as the Hereford syndrome, right? Or we call it as the Hereford syndrome. That is what you will observe in case of the sarcoidosis. Then how do you treat these patients with the Sjogren syndrome? The treatment in case of the Sjogren syndrome, symptomatic treatment, where you need to give the artificial tears for dry eyes and as well as lubricants. And for dry eyes, you need to give the cyclosporin as well, that can suppress the immune reactivity. And next is for xerostomia, where there is dry mouth. For dry mouth, you need to give pilocarpine or the cevimeline. And in systematic, because most common extraglandular manifestation is arthritis, for which you need to give NSAIDs for arthritis. Okay. And apart from NSAIDs, if the individual is not responding to NSAIDs, you need to give corticosteroids. And in severe cases, you need to give the immunosuppressants, that is rituximab should be given. And how is the overall prognosis, right? Quality of the life is very significantly affected. Why? Because there is dry eyes and dry mouth. But lifespan of the individual is usually normal, right? But when will you have the poor prognosis? If there is systemic involvement, then the individual will have poor prognosis. If there is systemic involvement, right? And if there is lymphoma involvement also, then the individual can have the poor prognosis. Okay. So this is about the story related to the Sjogren's syndrome. So to quickly recap about the Sjogren's, autoimmune condition, dry eyes, dry mouth, ratio 9:1 between females and males, pathogenesis lymphocytic infiltration, that is CD4 plus T lymphocytes into the salivary and lacrimal glands, primary Sjogren's, isolated disorder, secondary Sjogren's associated with other autoimmune disorder, right? And the key symptoms will be in the form of dry eyes and dry mouth. Extraglandular manifestation, the most common extraglandular manifestation will be in the form of arthritis and arthralgia, right? The autoantibodies that you observe is anti-Ro and anti-La. Diagnostic test, Schimmer's test for lacrimal secretion, cylometry for salivary secretion. Labial biopsy, highly sensitive and highly specific. Differential diagnosis, sarcoidosis. Treatment, symptomatic treatment. And along with that, you need to give cyclosporin for dry eyes, pilocarpine or cevimeline for xerostomia, and this for systemic involvement, NSAIDs for arthritis. In severe cases, rituximab. Quality of the life is compromised, but lifespan is normal. But the individual is said to have poor prognosis if there is systemic involvement. That is about the Sjogren's, right? Yeah. Yes, Sia Mirza. We are all doctors. We treat the patients. And by the way, who are you, Sia Mirza? By mistake, you have joined this channel. Chalo, TK. So we'll move on to the next topic, that is the systemic sclerosis or scleroderma. Right. Now, regarding the systemic sclerosis or scleroderma, yes, please answer this question. I am second year MBBS student from Pakistan. Sia Mirza, I think this particular session is very early for you to attend, right? You can save this and you can download this session. And by the time when you reach your fourth MBBS, then you can watch this session. I hope that will be useful at that time for you, right? But otherwise, this particular session is little early for you to get through with. Chalo. Like, we'll move on to the next topic, that is the systemic sclerosis. Yes, answer this question. We have a 50-year female patient presenting into the rheumatology clinic with complaints of the skin changes and difficulty in opening the mouth. Upon examination, there is a tendon friction rub and she reports experiencing dry mouth. She also mentions a history of Raynaud's phenomena. Which subtype of systemic sclerosis is most likely be associated in this patient? Very good. So it is the limited cutaneous variety of the systemic sclerosis. Why? Because you have only the skin changes, right? And there is difficulty in opening the mouth. And the patient is having Raynaud's phenomena. That is also, again, the cutaneous manifestation. And there is tendon friction rub. That is because of the fibrosis of the skin within the fingers. That is also cutaneous manifestation. So visceral organ involvement is not there. Because the visceral organ involvement is not there, that is the reason why we consider that this particular patient is having a limited scleroderma, right? Now, shall we start with the systemic sclerosis? Right, let us start with. Now, if you take the definition of this particular scleroderma, right? Definition of the scleroderma. This is also a chronic disease, This is also a chronic disease where you have the abnormal accumulation of the fibrous tissue not only in the skin but also in the internal organs. Right? And this is also an autoimmune disease. That is the reason why it is more common in females rather than males. And apart from systemic sclerosis, or apart from the diffuse scleroderma and limited scleroderma, we have one more important form of scleroderma called localized scleroderma. And this localized scleroderma, the name which is given to this is morphia. Right? This is morphia. Okay. And this is very common in children. This is very common in children. What is the problem here? The problem here is there is excessive fibrosis, which is triggered by abnormal immune response. What are the antibodies? The antibodies that you will have is the anti-nuclear antibody, anti-topoisomerase antibody, and anti-RNA polymerase 3. These three are the important antibodies, but out of which your anti-nuclear antibody, it is not specific because it is present in many other conditions. Now, what will be the first important manifestation that you will have in case of scleroderma? That will be in the form of Raynaud's phenomena. Then, what are the other skin manifestations in case of scleroderma? That will be in the form of increase in the thickness of the skin, that is sclerodactyly, right? Followed by that, you have leather-like skin, pitting scars, and tendon friction rubs. And you also have systemic involvement. That systemic involvement, gastrointestinal involvement can be there, where there is fibrosis of the lower esophageal sphincter, due to which there is GERD and as well as dysphagia. Lung involvement will be there, that will be in the form of interstitial lung disease. Kidney involvement will be there in the form of renal artery stenosis. Cardiac involvement will be there in the form of restrictive cardiomyopathy and dilated cardiomyopathy. So these are like multi-organ involvement that you will have in scleroderma. And as I have said you, we have two forms. One is limited scleroderma and diffuse scleroderma. Limited scleroderma, you need to remember this crest syndrome. Very, 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 very important. What is this crest syndrome? Where you have calcinosis, Raynaud's phenomena, esophageal dysmotility, sclerodactyly, and as well as telangiectasia. This will be your limited scleroderma. Whereas in diffuse scleroderma, what did I tell you? Along with skin, multiple other organs are affected. What are the organs which are affected? GIT, lungs, kidney, heart. These are the organs which are affected in diffuse scleroderma. Right? ANA will be positive, but that is not specific. And you have two forms of scleroderma, limited and diffuse scleroderma. Now, where is it you will have this anti-topoisomerase antibody positive? Remember, in diffuse scleroderma, your anti-topoisomerase antibody will be positive. Where is it you will have anti-centromere antibody that will be positive? That will be positive in limited scleroderma, that is CREST syndrome. And because it's an inflammatory condition, the ESR will be elevated. Right? And how is that you will be able to evaluate the lung involvement, CT and as well as MRI? And what is that lung involvement? That will be in the form of interstitial lung disease. Now, because it is an interstitial lung disease, what does the pulmonary function test show? Pulmonary function test show that there is restrictive lung disease, where your FEV1 by FVC, FEV1 by FVC will be more than or equal to 70%. That is what you will see in case of pulmonary function test, right? And what will happen to the DLCO, diffusion capacity of the lung for carbon monoxide? It is reduced. Next, coming to complications. In case of scleroderma, the complications will be pulmonary hypertension. Why pulmonary hypertension? Because in scleroderma, you have interstitial lung disease, which is causing hypoxia. And hypoxia will cause pulmonary artery vasoconstriction, resulting in pulmonary hypertension. And this pulmonary hypertension is considered as the cause of death in patients with the scleroderma. And the other complications will be in the form of ILD. Why is that there will be renal crisis? Renal crisis will be there mainly whenever these patients develop renal artery stenosis. Done? Then gastrointestinal hypomotility will be there, and as well as the cardiac fibrosis also will be there in these patients. Then what are the other treatment options in these patients? The other treatment options are, because these patients are having the dysphagia, GERD is there. So you need to give the proton pump inhibitors. That is mainly for GERD. These patients, if they have arthritis, you need to give NSAIDs. And as I have said you, like ILD will be there. And for that particular ILD, the drugs that you should give is mycophenolate mofetil, cyclophosphamide, or nintedanib. And the cause of death is pulmonary arterial hypertension. So how will you reduce the pulmonary artery pressure? By giving PA lowering pressure drugs, that is sildenafil, which is a phosphodiesterase inhibitor, bosentan, and as well as the prostacyclin. Next, I is saying you about the renal crisis. Why is that due to renal artery stenosis? Whenever there is renal artery stenosis, there is activation of RAS. So for that, what we should give? You should give the ACE inhibitors. And overall, how will be the prognosis in these individuals? 9-year survival rate is around 40%. But in which group of scleroderma, you will have poor prognosis. So please remember, mainly whenever there is diffuse scleroderma, then they are considered to be having poor prognosis. And the other poor prognostic features are older age and as well as lung involvement. Because whenever there is lung involvement, there is development of pulmonary arterial hypertension, and that can cause the death in the individual. Okay, so this is about the story related to the scleroderma. Right. Review on infectious disease. Amzad, no. Because infectious diseases that will be done in your microbiology, right? So I will not do infectious diseases here. Chalo. Let me quickly recap about the scleroderma. Chronic disease, abnormal fibrous tissue accumulation, autoimmune condition, so more common in women rather than men, right? You have an trigger by the abnormal immune response. The antibodies will be ANA, anti-topoisomerase, and anti-RNase polymerase 3. Raynaud's phenomena is the first manifestation. Skin sclerodactyly and pitting scars. Multiple organ involvement, GIT in the form of GERD, lung involvement in the form of ILD, kidney in the form of renal artery stenosis, and heart in the form of cardiomyopathies. Right? Two forms, limited and diffuse scleroderma. Right? And in diffuse scleroderma, anti-topoisomerase. Limited scleroderma, anti-centromere antibody. Pulmonary function test will show you that there is restrictive lung disease, where FEV1 by FVC will be more than or equal to 70%. Cause of death, pulmonary hypertension. Treatment, you need to give proton pump inhibitors for GERD. Lung involvement, you need to give mycophenolate mofetil. Right? And pulmonary arterial hypertension, you need to give sildenafil and as well as bosentan. Renal crisis, you need to give ACE inhibitors. Actually, drug of choice will be steroids. Why is that drug of choice is considered steroids? Because in the pathogenesis, what did we discuss? It is triggered by abnormal immune response. So you need to suppress the immune reactivity. So for that, you need to give the steroids. Okay. And how will be the prognosis? Poor prognosis, mainly in case of diffuse scleroderma. Done. So that is about the story related to scleroderma. Okay. Next topic for the discussion, that is base hits. Next topic for the discussion will be base hits. Yes. All of you, are you ready with the base hits? Shall we start with the base hits? Chalo, we'll start with the base hits. So base hits, this is also a multi-system inflammatory disorder. Multi-system inflammatory disorder. What is the pathognomic feature of the base hits? That will be ulcers. Where will be these ulcers? Oral ulcers and genital ulcers. And apart from these ulcers, you have the skin lesions and then ocular involvement in the form of anterior and posterior uveitis, and there will be also vasculitis. Then, and what is the age group at which you see base hits commonly? Young children. And in which countries this is very common? It is common in the ancient Silk Road regions. That is Turkey. Turkey is most common. What is the HLA association? B51 is the HLA association, right? And what is the manifestations? The key symptoms are oral ulcers, which are very painful, aphthous ulcers in the oral cavity. Genital ulcers, they scar. Oral ulcers, there is no scar formation. Genital ulcers, there is scar formation. And both of them, they are very painful. And skin manifestation will be in the form of erythema nodosome-like lesions. Ocular involvement will be in the form of anterior and as well as the posterior uveitis. And it is a multi-system involvement, right? CNS involvement can be there in the form of sterile meningitis and cranial nerve palsy. Gastrointestinal involvement can be there in the form of ulcers over the ileum and as well as the cecum. And it will also cause vasculitis, that is mainly pulmonary artery aneurysms. There can be deep vein thrombosis as well. Arthritis will be there, that is in the form of non-deforming arthritis. Okay, so this will be the other manifestations. So what are the complications? That is pulmonary artery aneurysm. And whenever this pulmonary artery aneurysm rupture, these patients will develop a life-threatening hemorrhage. These patients will develop a life-threatening hemorrhage. What is the diagnostic criteria? Diagnostic criteria is recurrent, painful oral and the genital ulcers. Skin manifestation will be in the form of erythema nodosum. And how will you diagnose? You need to do a skin hyperreactivity test. And that skin hyperreactivity test is the Part-1 test that will be positive. But as such, is there any specific diagnostic test? No. The HLA-B51 will be positive, and acute phase reactants like ESR and CRP is being elevated. So how do you treat these patients? The treatment is by, like the mucocutaneous lesions have to be treated by the colchicine, topical steroids, and apremilast. And if the disease is like severe disease, you need to give prednisolone and azathioprine. And if there is the CNS or ocular involvement, you need to give the infliximab, cyclosporin, or cyclophosphamide, right? So these will be the treatment in case of Behçet's. And how is the life expectancy? Normal life expectancy. But what would be the reason for the morbidity? The reason for morbidity will be mainly the blindness, because there is anterior and as well as posterior uveitis in this patient. So this is about the Behçet's. So Behçet's is what? Multi-system involvement, right? And commonly seen in young adults, commonly observed in Turkey. HLA-B51 positive. The pathognomic manifestation, oral ulcers, that too painful ulcers in the oral cavity, and they don't scar. And that too a recurrent oral aphthous ulceration. CNS manifestations, sterile meningitis. Vasculitis, pulmonary artery aneurysm. Complications, this pulmonary artery aneurysm can rupture, causing life-threatening hemorrhage, right? And there is no specific diagnostic test. Mainly the HLA-B51 will be positive and the Part-1 test will be positive. The treatment is you need to give colchicine and as well as topical corticosteroids. And in severe cases, you need to give the infliximab. Severe cases, prednisolone. CNS or ocular manifestations, you need to give infliximab, right? So that is about the treatment. Yeah, these are all previous year topics. These are all previous year topics, definitely. And yeah, DVT may anticoagulation. Yeah, if there is development of DVT, definitely we give anticoagulation. Definitely we give anticoagulation. Okay, chalo. Shall we start with the next topic, that is gout or the gouty arthritis? Gout or gouty arthritis. Answer this question. Shinavas, yes. Negatively birefringent crystals. Monosodium urate crystals. Shinavas, where do you have positively birefringent crystals? Where is that you'll have positively birefringent crystals? Positively birefringent crystals are observed in pseudogout. In pseudogout, you will have positively birefringent crystals. And the name of the crystals are the CPPD crystals. CPPD crystals. That is calcium pyrophosphate crystals. Calcium pyrophosphate dehydrogenase crystals. Okay, right. So the most initial treatment that you have to give in case of acute gout will be the ice pack application. That will be ice pack application. Right. Yeah, yes. In pseudo gout, it is the knee joint, but in case of gout, it is the first metatarsophalangeal joint. Okay, right. Let us start with a quick discussion related to the gout. So, gout, if you take, it is the disorder of the purine metabolism. It is a disorder of the purine metabolism, and that will lead to increased production of the uric acid or maybe decreased excretion of the uric acid. So basically, what is the problem here? The problem here is the levels of the uric acid is increased, right? Why this particular levels of the uric acid is increased? Either because of the increased, yes. So either because of the increased uric acid synthesis or decreased uric acid excretion. Right. And the joint which is commonly affected is first MTP, where you have the accumulation of the monosodium urate crystals within the joint, right? And it is more common in men rather than women. More common in men rather than women, right? And pathophysiology, if you observe, the hyperuricemia, whichever is there, the uric acid which is increased, that will go and accumulate within the joints. There will be supersaturation of the synovial fluid with the urate. And that particular urate is converted into crystals. And that too, it will be a monosodium urate negatively birefringent needle-shaped crystals. The first joint which is affected is the MTP, followed by that midfoot, ankle, and knee. Risk factors, very, very important risk factors. Alcohol consumption, uric acid spikes up. High purine diet, because it's a disorder of the purine metabolism. So the uric acid increases. Thiazides and loop diuretics, uric acid increases. Low dose salicylates, they will also increase the uric acid. So what is the diagnosis? Hyperuricemia. But this hyperuricemia, we cannot consider it as a definitive diagnostic test, because in some cases of acute attacks, the uric acid may be normal. In some cases of the acute attacks, the uric acid can be normal, right? And what is a confirmatory test? The confirmatory test is the synovial fluid analysis, where you have negatively birefringent needle-shaped monosodium urate crystals. What will be the radiological imaging finding? Radiological imaging finding is there will be punched out erosions, and that we describe it as the rat bite lesions. What is the treatment that you will give? In acute attack, you need to give NSAIDs or aspirin. I'm sorry, we don't give aspirin. I'm very sorry. We give indomethacin, colchicine, and glucocorticoids in case of severe conditions. And in chronic gout, you need to give xanthine oxidase inhibitors, that is allopurinol and febuxostat. Or you have a uricosuric agent, that is probenecid. Uricosuric agent, that is probenecid. But please remember, these chronic drugs, that is your allopurinol and febuxostat, they are not useful in acute attacks. And what is a complication? This particular uric acid can accumulate within the soft tissue in the form of the tophi. And it can accumulate within the kidney in the form of gout or gouty nephropathy. And the uric acid can accumulate in the form of the renal stones. So these are the complications. Okay. And coming to the pseudogout. Pseudogout actually mimics the gout, but the joint which is commonly affected is knee joint. And the crystals that are being accumulated is calcium pyrophosphate dehydrogenase crystals. How will you diagnose? Same, joint aspiration, but these are positively birefringent. Then how do you treat these patients? You need to give NSAIDs. You need to give NSAIDs, okay, in case of pseudogout. So this is about your gout and as well as the pseudogout, okay. So, right. So for those newcomers who are joining this particular session, let me just tell you again. The PDF of this channel is present on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba, and you can download this PDF from this Telegram channel. Done? Right. Okay. Now let us take up the next topic, that is vasculitis. Right. So if you take this, the vasculitis, what exactly is the problem here? Here you have the inflammation and destruction of the blood vessels. And how do you classify this vasculitis? We classify the vasculitis depending upon the vessels which are being affected. Like you have large vessel vasculitis, medium vessel vasculitis, and as well as backend team, please don't talk. It is audible to us and it is giving a lot of disturbance. Procm backend team, please don't talk or mute yourself. Okay. Now, we have large vessel vasculitis, medium vessel vasculitis, and as well as the small vessel vasculitis. Large vessel vasculitis, it mainly affects the aorta. And what are the examples of large vessel vasculitis? That is Takayasu and giant cell arteritis. And what are the examples of medium vessel vasculitis? That is polyarteritis nodosa, Kawasaki disease, and as well as the Buerger's disease, which is nothing but thromboangiitis obliterans. Then small vessel vasculitis. What are the examples of the small vessel vasculitis? That includes Wegener's, Church-Strauss syndrome, and as well as the Henon-Schollen's purpura. Right? These are the examples of the small vessel vasculitis. And one more important example of the small vessel vasculitis is what? That is microscopic polyangiitis. Right, microscopic polyangiitis. And all these vasculitis, let me tell you, they are the disorders of multiple system involvement. So multi-organ involvement will be there in these patients with the vasculitis. Out of all these, let me just tell you some important questions. The important questions are related to ANCA. C ANCA, your Wegener's will be positive. P ANCA, that will be positive in case of the microscopic polyangiitis and as well as the Church-Strauss syndrome. And in majority of the conditions, because the inflammation is the key point, the treatment drug of choice will be prednisolone. And in severe disease, we give cyclophosphamide and rituximab. And in specific conditions like Kawasaki, you need to give intravenous immunoglobulin and aspirin. And if there is renal involvement, you need to give mycophenolate mofetil. Okay. Now we'll try to take up the individual conditions. Right. Answer this. We have a 10-year-old child presents with red raised rash on the buttocks and legs. The mother reports that the child also has the joint pains, abdominal pain, fresh blood in the stool yesterday. Laboratory investigation reveal elevated levels of the IgA. What is the most likely diagnosis? Yes. Anyone? Right, good. So it is a case of the Heenan-Sjölin's purpura. So Heenan-Sjölin's purpura, the another name for this is, it is the IgA vasculitis. The another name for this is the IgA vasculitis, right? Which is a complex immune-mediated vasculitis. It's a complex immune-mediated vasculitis and it's a small vessel vasculitis. Okay. And in case of the Heenan-Sjölin's purpura, you should have a tetrad. What is that particular tetrad? The tetrad that should be there is H, S, and P. These P I will write 2 times. What is H? H stands for the hematuria. The H stands for the hematuria. S stands for the skin abnormality. That will be in the form of palpable purpura. P stands for pain in the abdomen, right? Pain in the abdomen. And another P stands for pain in the joints. Okay. Now, in the diagnostic criteria, 4 important criteria is there. Out of 4, at least 2 should be there. Number 1, purpura, palpable purpura. Number 2, the abdominal bowel angina, where you have the GIT involvement. Okay. Then next important is diagnostic picture will be biopsy, right? Where the biopsy will show you that there is IgA vasculitis. Right, where you'll have the IgA vasculitis. Okay, that will be the biopsy picture, right? And what is the age group at which you'll be seeing this Heenan-Sjölin's purpura? Less than 20 years. So out of 4, minimum 2 should be there for diagnosis of this IgA vasculitis. And remember, your IgA nephropathy is different. IgA nephropathy, that will be your Buerger's disease, where you have recurrent hematuria. Whereas IgA vasculitis is different, which is the Heenan-Sjölin's purpura, right? So if you take this Heenan-Sjölin's purpura, this is the summary. So skin involvement will be in the form of palpable purpura. Gastrointestinal involvement will be in the form of abdominal pain and melena. Kidney involvement will be in the form of the hematuria and proteinuria due to glomerulonephritis. Joint involvement will be in the form of arthritis. And when you do a skin biopsy is considered as the investigation of choice. Right? And what is that you will be observing in the skin biopsy? You will notice that there is presence of IgA and as well as C3, right? And in severe cases, the renal biopsy may be helpful. And what will be the clinical features? Palpable purpura, abdominal pain, and as well as the hematuria, right? Then how do you treat these patients? Treatment completely depends upon the severity of the disease. If the individual is having mild disease, supportive care, like where you will give hydration, NSAIDs for joint pain. For severe disease, you need to give prednisolone. For severe disease, you need to give prednisolone, that is corticosteroids have to be given, right? But if the individual is having a rapid progression, then rituximab or plasma exchange has to be done. And how will be the prognosis? It is generally self-limited in children, right? But adults may develop the chronic renal disease. Adults may develop chronic renal disease. This is about your Heenan-Sjölin's purpura, which is nothing but your IgA vasculitis. And another important vasculitis is Kawasaki, which is a medium vessel vasculitis. Answer? Yeah. Yes, Amjad. How do I know that it is a severe disease? Yes, Amjad, if suppose, where is that? Yeah. If there is the involvement of all the 4, that means there is palpable purpura, there is also arthritis, there is also hematuria, right? And there is also abdominal pain. When all these four are there, then you should consider it as severe disease. Okay. Yes, Amzad, is that clear, Amzad? Right. Now, which of the following is the most appropriate treatment for Kawasaki? Yes, the most appropriate treatment for Kawasaki is what? That is intravenous immunoglobulin. Chalo. Now, let me take up the discussion of the medium vessel vasculitis, that is Kawasaki. So, Kawasaki, it predominantly affects the children. It predominantly affects the children. Okay. And in this individuals, what is the characteristic finding? Along with fever, these patients will develop mucocutaneous lymph node syndrome. Mucocutaneous lymph node syndrome. 80% of the cases, it occur in children under 5 years of age. 80% of cases, it occurs in children under the 5 years of age. And it is more common in boys rather than girls, right? And in acute phase, what is the manifestation? Fever. And this particular fever should be there for more than 5 days. That's a very, very important manifestation in Kawasaki. And I said you it is mucocutaneous lymph node syndrome. You will be having, or the patient will be having the cervical lymphadenopathy, and the tongue will be like strawberry tongue. What will be the vessel that is commonly affected? Coronary artery. And that coronary artery involvement will be in the form of the coronary artery aneurysm. And other cardiac manifestations will be myocarditis and pericarditis, right? And what will be the laboratory manifestations? Because it's an inflammatory condition, the ESR and CRP is being elevated. ESR and CRP is being elevated. And the other features that you'll have is neutrophilia, thrombocytosis will be there after 1 week, hypoalbuminemia, and echocardiography is done in order to look for the coronary artery abnormality. And then how do you treat? So treatment completely depends upon whether the patient is presenting in acute stage or whether the patient is requiring long-term treatment. In acute stage, the intravenous immunoglobulin and aspirin should be given. Then what is that which is required as a long-term? Aspirin should be given in order to prevent the coronary artery thrombosis. And if at all, if there is coronary artery thrombosis, you need to give fibrinolytic agent. Then how is the prognosis in this individual? For example, if you are starting the treatment early, the prognosis is good. If you are starting the treatment early, the prognosis is good. But in untreated cases, they have significant risk of the coronary artery aneurysm. In untreated cases, there is significant risk of the coronary artery aneurysm, and there will be long-term cardiac complication. So this is about your Kawasaki. Done? Okay. Now, yeah, Amzad, how can I give aspirin if the patient has aneurysmal risk for the bleed? See, in case of the aneurysm, if it is there, it is not that you cannot give the aspirin. Why? Because if you don't give aspirin, what will happen? Whenever there is coronary artery aneurysm, there can be stasis of the blood. Right? There is slow movement of the blood. That is equivalent to stasis. This can precipitate the thrombus formation. Right? And once there is a thrombus, the individual will develop MI. So to prevent this thrombus, I need to give a low dose aspirin. To prevent this, you need to give low dose aspirin. I'm not saying like high dose aspirin that we give in case of acute rheumatic fever. Low dose aspirin has to be given. Okay. Right. Now coming to the large vessel vasculitis, and this large vessel vasculitis is Takayasu. Takayasu. Okay. So Takayasu, which is a large vessel vasculitis, it is very common in individuals of age less than 50 years. Right? Less than 50 years. Right? And in these patients with Takayasu, the common vessel that is affected is left subclavian artery. That is the reason why the blood supply to the radial artery will get compromised. And the individual will not, you will not be able to feel the pulse. That is why it's called pulseless disease. And what are the symptoms in these individuals with Takayasu? Fatigue, visual disturbances, and hypertension. This hypertension, that is mainly due to renal artery involvement in patients with Takayasu. Then how will you diagnose? The investigation of choice is MRI of the aorta. MRI of the aorta, MR iotography. And it's an inflammatory disorder. ESR will be elevated. And it's an inflammatory disorder. You need to give corticosteroids. And if there is multiple organ involvement and refractory scenario, biologicals should be given. That is the methotrexate. So that is about your Takayasu, which is nothing but pulseless disease, or it is also called iotoarthritis. Right? It is also called the iotoarthritis. Right? Yes, Harmandeep. Hi. Right? And yes, Harmandeep, this particular session will be useful even for the MDS entrance exam as well. This will be a quick revision. So even for you also, this particular sessions will be useful. Right? Now, the next important form of large vessel vasculitis will be the temporal arthritis. Temporal arthritis, it is very common in age group more than 50 years. And what is the most common vessel that is affected? The most common vessel affected is the temporal artery. That is the reason why it is called temporal arthritis. That is the reason why it is called temporal arthritis. Okay. And the temporal artery will be inflamed and it is very tender to touch. And these patients will have the headache. And due to the involvement of the ophthalmic artery, these patients will have the visual loss. And due to the involvement of the temporal artery, the blood supply to the muscles of the mastication will be compromised. And thereby these patients will have the jaw claudication. And how will you confirm the diagnosis? By doing the temporal artery biopsy. Temporal artery biopsy, when you do, you will notice that there is granulomatous inflammation. You will notice that there is granulomatous inflammation. And ESR is being elevated, that will be more than 50 millimeters per hour. And it's an inflammatory disorder, so you need to give immunosuppressant, corticosteroid. Refractory cases or in severe cases, you need to give the tocilizumab. You need to give tocilizumab. Okay. So these patients will have the important symptomatology in the form of headache. Then next, let me take up another important medium vessel vasculitis, that is polyarthritis nodosa. So polyarthritis nodosa, let me tell you, it affects all the organs. But the organ that is spared in polyarthritis nodosa is lung. If lung involvement is there in the clinical scenario, it is not polyarthritis nodosa. And what are the symptoms then? Hypertension and mononeuritis multiplex. How will you diagnose? By doing biopsy. Biopsy will show you that is necrotizing arthritis. How do you treat polyarthritis nodosa? It's an inflammatory condition, immune-mediated disorder. Corticosteroids should be given, and as well as the cyclophosphamide. Right? Cyclophosphamide. Okay. And another important vasculitis is small vessel vasculitis. That is Wegener's and Church-Strauss. Another name for Wegener's is what? Granulomatosis with polyangiitis. And in Wegener's, you have a triad. What is a triad? Right? So you have a triad. Okay. Yes, Almarva, right? So I said you, this PDF is available on my Telegram channel. That is Medicine Made Easy by Dr. Rajesh Gubba. And you can download this PDF from my Telegram channel. Okay. Right. Chalo. So granulomatosis with polyangiitis, that is Wegener's, where you have a triad, where you have the upper respiratory tract involvement, lower respiratory tract involvement, and you also have the kidney involvement in the form of the glomerulonephritis. And symptoms will be in the form of like sinusitis, hematuria, and saddle nose deformity. Why is it they have that saddle nose deformity? Because there is collapse of the nasal cartilage. That is the reason why you'll have saddle nose deformity. What is the investigation of choice? The investigation of choice will be Cianca. And how do you treat? The immunosuppressants like rituximab and cyclophosphamide will be given, right? Then the next important is the eosinophilic granulomatosis with polyangiitis, which is nothing but the Church-Strauss syndrome. So Church-Strauss syndrome, the classical picture will be asthma. In any form of vasculitis, if asthma is there, that will be Church-Strauss. And along with that, these patients will have eosinophilia. And how will you diagnose? Along with elevated P-ANCA, you will have increase in eosinophil levels because the P-ANCA is also elevated in microscopic polyangiitis as well. Then how do you treat this eosinophilic granulomatosis with polyangiitis? Corticosteroids. In severe cases, the azathioprine and as well as the mepolizumab should be given. Right? Mepolizumab and azathioprine should be given. Okay. So this is about granulomatosis with polyangiitis. And last important form of the microscopic polyangiitis, last important form of small vessel vasculitis is microscopic polyangiitis, where you have the involvement of venules, capillaries, and as well as arterioles. So what will be the problem? There can be rupture of the capillaries within the lung resulting in pulmonary hemorrhage, and there can be rupture of the glomerular capillaries that will be resulting in glomerulonephritis. And in microscopic polyangiitis, you will have P-ANCA. And P-ANCA is not only present in microscopic polyangiitis, even in Church-Strauss syndrome, you'll have the P-ANCA being present. And how will you diagnose? Biopsy will also show you that there is necrotizing vasculitis. How do you treat? Rituximab and as well as the cyclophosphamide should be given. Rituximab and cyclophosphamide should be given, right? So this is about the story related to the vasculitis. So all the vasculitis in nutshell, the entire vasculitis in nutshell. Okay, then coming to the next topic, that is sarcoidosis. Yeah, answer. Chalo, answer this. Right. A 35-year-old male presents with 2 months history of persistent dry cough, fatigue, and shortness of breath. Biopsy shows presence of naked granulomas, HRCT, chest gallium scan, first line treatment. Yeah, yes, Pratik, thank you very much. Yeah, Antique, thank you very much. Shanavas, thank you very much. Adhikari, thank you very much. Right? The appreciations, whatever you give, is the one which is a key motivator for the educator. Right? And you try to motivate a lot, the educator will try to give a lot. Okay? And ये session होने के बाद comment section में, in comment section also, please try to write some good comments. That will motivate us a lot. Okay? Right. Chalo. So what is a diagnosis here? Diagnosis here is, so in the gallium scan, what is that you are having is panda sign. You are having a panda sign. This is number one. Then in the CT, what is that you are observing is, in the CT, you are observing the galaxy scan. Right? In the CT, you are observing galaxy sign. Okay. So CT showing galaxy sign and panda sign in the gallium and the presence of the naked granulomas. Presence of non-caseating. Naked granulomas means non-caseating granulomas. So galaxy sign, panda sign, naked granulomas. All these, they point towards sarcoidosis. All these, they point towards the sarcoidosis. So what is the first line treatment in sarcoidosis? Steroids. Steroids is what we'll give, right? Now, that is the first line treatment. Agar, if the patient is developing Cushing syndrome due to steroids, what is a steroid sparing agent? The steroid sparing agent will be the hydroxychloroquine. Hydroxychloroquine will be steroid sparing agent, right? When will you give methotrexate? Methotrexate is another steroid sparing agent, right? And what is the third steroid sparing agent? Azathioprine. When will you give like infliximab? You will give infliximab whenever there is severe or refractory cases. Severe or refractory cases, you should give infliximab, right? So this is about the treatment in sarcoidosis. Let me just quickly recap the sarcoidosis. Okay. What is the sarcoidosis? This is also a chronic inflammatory disease where you have the presence of non-caseating granuloma in the lungs and other organs. But the common organ which is affected is lung. Along with lung involvement, you have the bilateral hilar lymphadenopathy, which is the hallmark feature in patients with sarcoidosis, right? And the age group at which you see this sarcoidosis, 20 to 40 years. What is the pathogenesis? That is, you have a trigger. What is the trigger? The trigger is by the Propionibacterium acne, then Mycobacterium tuberculosis. These are the triggers, right? And this particular triggers will trigger the immune system and there will be immune reactivity. And in these individuals, you have inclusion bodies. What are the inclusion bodies? Shaman bodies, asteroid bodies, and we have one more, residual bodies. One more, residual bodies. So these are the inclusion bodies, Shaman bodies, asteroid bodies, and then the residual bodies. Most common organ affected is lung. Lymph node involvement, bilateral hilar lymphadenopathy. Skin involvement will be there in the form of erythema nodosum and lupus pernio. And cardiac involvement will be there in the form of restrictive cardiomyopathy, and that is a cause of death in these individuals. So lung involvement, that will be in the form of interstitial lung disease. And due to this interstitial lung disease, they'll be having dry cough and dyspnea. Skin involvement in the form of this erythema nodosum and lupus pernio. Lymph node involvement, bilateral hilar lymphadenopathy. CNS involvement in the form of lymphocytic meningitis and optic neuritis. Ocular involvement will be in the form of uveitis and as well as the Zika syndrome, right? So this will be clinical features. And whenever you take the chest X-ray, apart from bilateral hilar lymphadenopathy, you have totally three types of chest X-rays in sarcoidosis: type 1, type 2, and type 3. Type 1, there will be bilateral hilar lymphadenopathy, but parenchymal involvement will not be there. Type 2, bilateral hilar lymphadenopathy will be there. Along with that, parenchymal involvement also will be there. Type 3, you will have diffuse parenchymal changes, but hilar lymphadenopathy will not be there. Hilar lymphadenopathy will not be there. Just give me 1 minute. Okay. Chalo. So these are the three important radiological patterns. And how will you diagnose? Because it's an inflammatory condition, ESR will be elevated, right? And the hypercalcemia will be there. Why? Because this non-caseating granuloma will be producing vitamin D. And there will be elevated ACE levels from this non-caseating granuloma. And if you take CD4 to CD8 ratio, it will be like 10:1. What is a confirmatory diagnosis? Confirmation is by your biopsy. Biopsy will show you that there is non-caseating granuloma, right? And Queen-Silsbach test we are not doing now. It was a good olden test, right? In the olden days, we were doing this Queen-Silsbach test. What are the special sign? That is lambda sign and as well as panda sign. This lambda sign and panda sign, that is by gallium-68 uptake studies. That is lambda and as well as panda, right? And because it's an inflammatory condition, so what is that you need to do? You need to give the corticosteroids. Refractory cases, what is that you need to give? Methotrexate, azathioprine, and infliximab, right? And whenever there is CNS involvement, that is when you need to give this methotrexate, azathioprine, and infliximab. Whenever there is CNS involvement, right? And what are the good prognostic signs? Okay, so if there is hilar lymphadenopathy or erythema nodosum, it's a good prognosis. But if there is progressive lung fibrosis, poor prognosis. And what will be the long-term complication? Restrictive cardiomyopathy, that will be causing arrhythmias and sudden cardiac death. Okay. So this will be the topics in connective tissue disorders, right? So with this, I'm done with the connective tissue disorders, and as well as what was the other topic that we have done? The hepatology. Okay. So I will stop for now. Right, I'm completely tired because continuously talking for almost 2 to 2.5 hours, right? So there is a complete fatigue in my voice. I'll just wind up the session right now. Tomorrow again at 7:30 we will start. So tomorrow we will start with the neurology first, because many of the students are asking the neurology. So neurology also I have made it in the form of tables. So please follow me tomorrow at 7:30 on the same YouTube channel. Definitely we will do neurology and as well as the pulmonology and some more topics if I have the the energy tomorrow once I finish the neurology and the pulmonology, right? But take it from me, granted, all the topics I will do, right? But I may be doing it in the split manner. All the topics, all the subtopics I will do, okay? And you just listen to these particular sessions, 70 to 80% of questions in general medicine you will cover by these topics, okay? Chalo. With this, we'll wind up this session. Thank you very much. See you tomorrow at 7:30.